you can get that slap cheek. What are the clues I'm getting? That is, there is a pharyngitis, which is a membranous or exudative. Tongue is white strawberry, latter red strawberry. Initially, there is a characteristic of that. Initially, you get a white strawberry tongue, and that latter get less like a ripe strawberry. That is the latter red strawberry. And there is generalized discombination, including hands and foots. So this is a classical white tongue followed by a strawberry tongue. So my diagnosis is clear. This is a scarlet fever. So this is the fascia lines where you get the rash. That's a scarlet fever with rash. You get mainly in axilla, groins. Now coming to case 2, it's a little bit serious case. It's a rash. There is a with a tender erythema. Nicolis sign is positive. What is the Nicolis sign? When there is a parching skin, when you pinch into the two finger, you get the parching of that skin. That is the Nicolis skin sign. Discombination is there of skin. It's in sheet. Lips and oropharynx are spared. Eyes are normal, but you can get purulent conjunctivitis. What are the clues? There is a widespread discombination, but patient is always comfortable. Patient is not toxic. There is circumoral erythema and radial crusting and fissuring around eyes, mouth and nose. So this is a 4 times yes, that is a Staphylococcus scarlet skin syndrome, which we can manage nicely, but you have to manage in ICU. This is a classical picture of a Staphylococcus scarlet skin syndrome. You can see the sparing of the mucosas. Now, the next entity is that erythroderma with hypotension. Initially, we have seen the without hypotension, without shock. So this is the case where there is a diffuse erythroderma. Discombination is later. Initially, there is a erythroderma with discombination later. Eyes, lips, oropharynx involved. Patient look very toxic, very sick. What are the clues I got? That there is a high-grade fever with a hypotension. It means patient is in a shock. So this is a toxic shock syndrome. You know, this is toxic shock syndrome is the main or causative organism as a staph or staphylococcus. So what are the diagnostic criteria for TSS? This is a major and minor. 3 major criteria should be there. That is the acute fever more than 38.8 degree, hypotension and rash. And what are the minor criteria? Minor criteria can be mucous membrane inflammation, vomiting, diarrhea, decreased platelet, liver, renal and muscle CNS abnormality. Either out of that, if there are 3 criteria of minor and 3 major criteria, you can diagnose it as a TSS. So again, lab criteria, there is increased TLC, increased polyps, coagulopathy is there, platelets are decreased, and exclusionary criteria, what are there should not be any other condition, another explanation other than this, and blood culture should be negative. So this is very important. So how to differentiate between whether it's a staph or whether it's a bistepto. In staph TSS, you get vomiting, prodromal duration is hours, only hours. Focal infection may be present, may not. Rash is must. And there is a multiple organ involvement. Whereas in TSS caused by streptococcus, that there is a usually flu-like illness. It takes hours to day. There is a soft tissue necrosis and rash may be present, may not be present. But there is a severe pain in case of streptococcus. There is a positive blood culture and definitely multiple organ involvement is there. So what are the red flags in erythema? The age more than 3 years, sick looking, increased serum creatinine and vomiting. Now coming to next entity, that is a PUO with rash. This is a PUO patient. If you take the careful history and if you clinically examine, there is a Ishar formation. HR is, I don't know what is the status of rickettsia here, but in our India we get multiple cases because of forest region and everything and urbanization. So maculopapular rash including palms and soles, there is edema and organomegaly. Patient deteriorate very fast. There is an increased SGPT, decreased platelet, liver is involved, splenomegaly is there. And when it go for a screening test, Bell-Pelix test, it get positive. And whenever good, the doxy or chloramphenicol dramatic response, patient recover within 48 hours. So this can be considered as one of the diagnosis tests for rickettsia. So rickettsia, this is a scrub typhus, which we get in hilly areas. So PU with rash involving palms and sole and response to doxychlorophenol, the diagnosis is a rickettsia. These are the multiple pictures. This first patient is in a ICU coma. This is a macular rash. You can see the involvement of sole. Lateral one HR is forming, and mainly you can get a ear is involved. There is a, if patient goes seriously, you have to get the necrosis of the skin, and this last picture is having a, this right corner picture, it's not working, so this is classical HR. So now coming to next case, this 1 to 4 week, it's child develop a rash 1 to 4 weeks after exposure to drug. Rash is pruritic, diffuse erythematous urticarial. There is organomegaly, periocular edema, generalized lymphadenopathy, hepatitis, there is nephritis, pneumonitis, encephalitis, multiple organ failure. What is the clue? There is a eosinophilia and atypical lymphocytes. So this is a DHS or drug responsive eosinophilic skin syndrome. Now coming to third case, persistent high-grade fever, more than 2 spikes a day, patient normal in between spike, there is arthritis, myalgia, arthralgia, and rash is erythematous, macule over trunk, evanescent. There is a lymphadenopathy and hepatosplenomegaly, that is the organomegaly. TLC, DLC, ESR, CRP, platelets, all are raised. So my diagnosis is a systemic onset JRA. Now next case is a PUO. This rash is seborrheic, petechial without thrombocytopenia. As you have to see that the rash is seborrheic, petechial without thrombocytopenia. There is all systems are involved. You see that lymphadenopathy is there, organomegaly is there, liver is involved, there is a pneumonia, there is a draining ears, otitis media, and you can get a diabetes insipidus, and always there is a bone involvement. So this is the Langermann cell histiocytosis. So what is the clue? Our clue is this involvement of organ, erythematous macrosotra. So this is the clue. So PS is very important in this case. Now coming to Kawasaki disease, one of the commonest entity which we miss never and one should not miss. That's why I'm taking a lot major time on this disease. So it's a uncommon disease or common but uncommonly diagnosed. Your antenna should be high. You should have a strong suspicion for diagnosis of disease. A patient with a fever more than 5 days plus 4 to 5 of the following, that is there is a conjunctival congestion which is non-executive. There is changes in oral mucosa. There is a rash, maculopapular. Peripheral extremity changes like edema, erythema of hands and feet, and periganglional discommission. You have to see the lymphadenopathy, and you always get that cervical lymphadenopathy. When I go for laboratory diagnosis, hemoglobin is decreased, but it's a normocytic, normochromic. TLC and polymorphs are increased. ESR, CRP, SGPT, and platelet counts are on higher side. There is sterile pyuria, but important is that echo. You get the findings on echo. So one should, or whenever you suspect Kawasaki, one should go for echo. That is very important. So what are the exclusion criteria for Kawasaki disease, which we never get? That exudative conjunctivitis, exudative pharyngitis, discrete oral ulcer, bullous rash, and generalized adenopathy. Whenever you get this criteria, don't say it's a Kawasaki disease. So why I am showing this all? Why the Kawasaki is special? Because it's having non-specific clinical finding, diagnosis mainly based on clinical criteria. Your important is we have to think of it. There are incomplete cases. Treatment is expensive. Thrombocytosis, periangle, this combination, that's late presentation. If you get late in diagnosis, we have to pay heavy price. If initially you can go for immunoglobulin and symptomatic diagnosis, but if you get delayed, the death is the only answer. That's why Kawasaki disease is very special. So at end, fever with rash, it's like a clinical syndrome. So we can divide it in non-toxic with maculopapular rash, sick with maculopapular petechial rash, fever with vesicular rash, fever with urticaria, nodules, erythroderma without hypotension and with hypotension, and PU with rash and Kawasaki disease. If you remember this thing and all three conditions in each, you will get diagnosis. That's why initially I told you the skin is such a sensitive organ that you can go to your final diagnosis on skin. Though it's the largest organ and protective organ, but our eyes should be open. One should be very sensitive while diagnosis, while examining patient. So always, whenever there is a skin fever with rash, always see for prodrome, always see for symptoms, and go for the clinical clues. That's my message for to. So fever with rash, never think only of viral exanthem. Always think beyond this. Thank you.
Hello. So thank you very much, Professor Vasant Kalatkarji, for the elaborative, pictorial, informative this presentation on the fever with the rash, and you have highlighted all the types of the rashes with the fever. So I invite Dr. Neelam Mohan Madam to moderate the session, and please join the chair.
Good afternoon, everybody. I think after a sumptuous meal, we can see the attendance, and also the fact that needs to be highlighted is pediatrics is quite often neglected. And I think I remember Saga saying yesterday that 30% everywhere, between 30 to 40% population is pediatric, and we need these to be highlighted in emergencies. And we have another speaker with us, Dr. Yogesh Parekh, and Dr. Yogesh Parekh is the secretary of the Indian Academy of Pediatrics, which is close to 50,000, a little less than that, pediatricians group, and he performs excellently his administrative job, and he's a teacher in the government institute there and an examiner for various. So without wasting time, may I request Dr. Yogesh Parekh to talk about the bleed approach in a bleeding, a management of acute bleed in a hemophilia. Just yesterday, was it yesterday or day before, we had the hemophilia day where we were trying to highlight it is not only boys who have hemophilia, the women who are carriers, the girls who are carriers, they bleed a lot during periods, etc. And so the theme of the hemophilia was even girls bleed. So that was the theme. And if the presentation is ready, may I request Dr. Yogesh to please start. Thank you.
So good afternoon after the lunch session. Thank you very much, Professor Basar and Atudar, Sitika, Ipet and Dr. Sagar for giving opportunity and inviting Indian Academy of Pediatrics to join all of you. So let me thanks everyone here, and I'm presenting the management of the acute bleeding with the hemophilia. So we all know the hemophilia. It is inherited bleeding disorder mainly associated with the deficiency of coagulation factor 8 and the factor 9. And the incidence of the hemophilia A in 1 in the 5,000 live male births, and the hemophilia B is in 1 in 30,000 live births in the male births. So what is the genetics of the hemophilia? The genes can be responsible for hemophilia A and B are the genes F8 and F9. It is located on the X chromosome. So it is a sex-linked disease. Let us see the hemophilia inherited patterns. Suppose the mother is carrier and the father is normal. So 50% children are normal. So the XY is the normal and the XX is the normal, but the one XY is hemophilia, and the one XX, the female child having carrier status. Suppose the mother is normal and father with the hemophilia, then both the siblings of the children are the normal, and both the females are carrier. Suppose the mother is carrier and father with hemophilia, then the XY is a normal, but double X, female is a carrier, one male is hemophilic, and the one female is having a hemophilia status. But it is very rare condition in the female having a hemophilia. But what Dr. Neelam Mohan Madam mentioned, the females having bleeding during the menstrual period, then sometimes we have to diagnose it. And Dr. Sagar, yesterday was the 17th April and the World Hemophilia Day. And the theme basically on the this access to the all, particularly it is based on the women and the girls that also bleed too. So this is the World Hemophilia Day yesterday, and we celebrated, observed that day, and particularly observation on the females. So however, some females also inherit hemophilia genes that bleeding symptoms, while the bleeding symptoms in the female are usually milder than the cases with the hemophilia, but we have to take care of that also. So hemophilia status in the globally, more than 2 lakhs cases of hemophilia A and 42,000 cases of the hemophilia B. In India, its prevalence of the 21,000 of hemophilia A and 3,500 cases in the hemophilia B. In the Turkey, it is more than 5,000 cases of the hemophilia, and adult cases are more than 3,000. So from the world, more than 8 to 10% of cases of the hemophilia patients globally are the India, and the diagnosis based on the hemophilia A and B is steadily increasing in the India. At the registry of the hemophilia is started since 2015, and the 2022 census saying it is more than 21,600 cases in the India. Let us see the clinical phenotypes. We have to stem the severe phenotypes, while the this factor 9 and the factor 8 concentration is less than 1% of the normal. So what is the normal? Normal is more than 50 to 150% is the normal, and these severe cases have a clinical manifestation of the spontaneous bleeding into joints or the muscles, predominantly in the absence of the identifiable hemostatic challenge. This, it accounts 29% of the patients. In the moderate form, it is less 1 to 5% of the normal, the range of the factor 9 or factor 8 concentration, and it is occasionally spontaneous bleeding, prolonged bleeding with the minor trauma or the surgery, and the mild cases 5 to less than 40% of the normal concentration, then the severe bleeding with the major trauma or the surgery and the spontaneous bleeding is very rare. So it also accounts the 34 percentage. So what are the signs and symptoms? Mainly while the intracranial bleed, then the prolonged headache, then epistaxis, neck swelling, then deltoid or forearm bleed or the bruising, the buttock bleeds, then the thigh or the calf bleeds, then the iliopsoas bleeds or soft tissue, and bruising is there. So early symptoms from the childhood, the blue patches and the bruise on the skin, then the gum bleeds, frenulum bleeds, and cuts and wounds which bleed a long time. See, this is the joints also involved, the calf muscles and the knee joints and the ankle joints and the forearms, and the eyelid edema also will be there. So let us have some workup for the hemophilia A and B. We have to clinically evaluate the case. We have with the history taking and the clinical examination with the high suspicion of the bleeding disorder. We have to do workup of the PT, APTT, bleeding time, and the platelet counts. If the PT, BT and the platelet count is normal and APTT is prolonged, then we have to see that preliminary investigation, the suspicion of the hemophilia. And for the confirmative diagnosis, we have to do the factor assay, factor 9 and factor 8. So with that, we can stamp the hemophilia B and A, or we have to additional workup for the whatever the mutation analysis on the mutation type and the risk of the inhibitors. So lab diagnosis, what we have discussed, if all the parameters are normal, then the adults or the child are normal, but if with the patient of the hemophilia A or B, then the APTT is prolonged and other parameters will be the normal. In vein-valve disease, the parameters PT and this APTT may be prolonged, but PT is normal and BT is normal or prolonged, and this platelet count is normal or reduced. And in case of the platelet defect, all the parameters belongs to BT is prolonged and platelet count is reduced. So let us have some case, the case-based scenario. The patient name ABC with the age of the 6 months and weight is 7 kg. It is scheduled for the circumcision, then the pre-operative investigation were done, it was normal, but after the surgery, the continuous bleeding of from the surgical side, this is the complaint is from the patient. So what went wrong? Some APTT was done, then APTT was prolonged, and factor 8 and factor 9 assay also done. So can be given factor 7 or APCC or factor 8 or factor 9. So this is the sum we have to investigate further for carrier detection and genetic mutation studies. So what are the treatment of the hemophilia? Whole blood or plasma or FFP or cryoprecipitate. Orally, we can give the epsilon aminocapric acid or tranexamic acid. Intravenous and subcutaneous drug like desmopressin, nasal drops available, desmopressin, clotting factors, non-clotting factor-based therapy, immunosuppressive, then the gene therapy, hemogenics for the hemophilia B, and the roctavian for the hemophilia A. So hemophilia, after the preliminary management, we have to see the price strategy and the early treatment with the clotting factor concentrations and the appropriate dosing. For this, we have to make what are the first aid measurements, the price. Price means protect. We have to protect ourselves, what the hemophilia child, then we have to rest for hour, then ice application, then the compress, and the E for the elevate. So timely within the 2 hours and adequate clotting factor concentration, it is critical to outcome. So this is the price mainly the base principal therapy. We have to see the clotting factor concentration. 2 types of the CFC are present. One is the plasma derived, one is the recombinant. So with the healthy donor, we have to introduce the plasma and we have to produce plasma derived factor 8. In the case of the recombinant, the human factor 8 genes is cloning done into the mammalian cells, and we have to produce these mammalian cells produce the human factor 8, that is the recombinant factor 8. So with this, what dose should be given to the patient? What are the principles of the dosing? Assume the following. So we need to see the baseline factor of level in the patient with the hemophilia. It is almost 0%. Or the need to raise the clotting factor levels to at certain minimal level that will stop bleeding, and it is depend upon the different size of the bleeding. Third is 1 unit of the per kg factor 8, it raise the plasma factor level almost 2%, while in case of the factor 9, it is approximately raised the 1%. So factor 8 dose concentration, mainly on the dose calculation for the number of units, body weight into desired level divided by 2. In case of the factor 9 concentration, dose calculation for the number of units, body weight into desired level. So it also depends on the size of the bleed also. So when the muscles and joints are, then we have to desire the level of the more than 40, then the ileoceous fluid is 60%, and vital organs like neck, throat, GI bleeding, genitourinary bleed, and the surgery post-operatively, we have to keep the desired level 50 to 80% of the this international units. Then after pre-operative surgery and in case of the intracranial bleed, we have to maintain the 100 desired level. So case 2, ABC, 8 years, and the weight is 25 kg. Non-case of hemophilia A had acute pain and swelling in the right knee joint. So here the knee joint is involved. So immediate management at home, again the price therapy, and then we have to look for the specifically for the joints. So it can be given the short half-life recombinant factor 8 concentration. Dose will be weight is 25 into 40 divided by 2. So 500 international units twice a day for the 3 days. If we are selecting the extended half-life recombinant factor 8, then we have to give the dose of 25 into 40 divided by 2 is a 500 units single dose. This is the duration, firstly short half-life for the 3 days, and the extended half-life we have to give for the single dose. If the bleed is recovered, then we need to counsel for the option of the prophylaxis treatment and the physiotherapy. If the similar bleed occurs in the non-case of hemophilia B patient, then the dose of the same treatment, how can we calculate this? Price therapy again, then short half-life recombinant factor concentration, we need to calculate into 25 into 40, 1000 international unit once a day for 3 days. And in case of the EHL, we have to calculate 25 into 40, 1000 IU single dose. So again, we have to counsel for the option of the prophylaxis of the treatment and the continued physiotherapy. So early treatment enables early resolution of bleeding. This World Federation Hemophilia guidelines presented in the management of the hemophilia, the acute bleeds should be treated as quickly as possible, preferably within 2 hours. So what is the importance? Hence the early resolution of the bleeds is also important if we have to think about disability-free hemophilia. So it reduces hospitalization, it requires fewer doses, and minimize the joint damage. So we need to care of these joints should be not damaged. So will everyone with the hemophilia develop inhibitors? No, only 30% of the severe hemophilia A and 10% of the hemophilia B will develop the inhibitors. So it requires more factors with little or no response than high breakup through the bleeding on prophylaxis. So what are the inhibitors in the hemophilia? Inhibitors are the antibodies that act against the replacement factor 8 or 9 and the cause continuous bleeding. The development of inhibitors is one of the most severe complications of hemophilia treatment and remains an important clinical challenge with the limited treatment options. So it is autoantibodies. So it is like acquired hemophilia. So impact of the inhibitors, difficult to treat the case, then the risk of the death due to intracranial bleed, and the worse joint disease and the quality of the life. So the more absenteeism from the work or the school and the frequent hospitalization should be there. Then the inhibitors, will factor 8 work? Will the bleed stops? We have to see for the low titer or high titer. If less than Bethesda units per ml, then then late responder or the high responders, it depends on the responders. Then we have to see the high titer more than 5 Bethesda units, and the bypassing agents. All the factor 8 dose will be neutralizing the bleeding continuously. So we need to for plasmic derived APCC or the this recommended factor 7A. So it is also bypassing the agents. These are the different types of the bypassing agents. Then the case 3, XYZ, age is 6 years, weight is 20 kg. Non-case of hemophilia with the inhibitor with acute pain and the swelling in the right thigh. So immediate management at home, again the price therapy. Then the treatment options. Treatment options are available, is mostly the FIBA we have to manage by the bypassing agents with the recombinant or the plasma derived. So this recombinant for the treatment of bleeds, what are the mechanisms of action? It works locally at the site of the vascular injury where the tissue factor is exposed and the activated platelets are found. So bleeding of the factor 7A or recombinant factor 7A activated to tissue perfusion, this initiates the coagulation generating small amounts of thrombin, and that pharmacological dose of this directly gives the thrombin thrust. So thrombin thrust leads to the formation of the stable hemostatic plug which controls the bleeding. So this is the bypassing agents in the inhibitory management, plasma derived and recombinant. This plasma recombinant is the plasma derived, and the recombinant is from the produced from the recombinant technology. The no dose capping in case of the R factor 7, then the congestion efficiency, the no amnestic response in the case of recombinant therapy, and the small volume and the rapid bleeding control will be there. So this World Federation of the 2020 guidelines recommend the recombinant factors 7. So dose and duration of the treatment with the factors 7 is in the case of the throat, neck, GI bleed, genitourinary, intracranial bleed, and minor surgery, dose is 90 microgram initially per kg, and the duration is varies every 2 to 3 hours, into 1 to 3 days. Total duration is up to 2 to 3 weeks, and every 4 to 8 or 12 hourly. In major surgery, 90 microgram per kg every 2 to 3 hours, and for 6 to 7 days initial management, then it is up to the 2 to 3 weeks in every 4 to 8 hours, 12 hours. So what is the FIBA? FIBA is an anti-inhibitory coagulation complex. It is a freeze-derived sterile human plasma friction with the factor 7, factor 8 inhibitor bypassing activity, and the prothrombin complex factors. It includes factor 2 prothrombin activated factor 10. So this is the hemophilia pathogenesis, and this is about the FIBA. FIBA is bypassing agent. Inducing and facilitating the thrombin generation. So this is regarding the FIBA dose in the spontaneous hemorrhage, joint, muscle, and soft tissue hemorrhage, minor or moderate bleeding. Then we have to consider dose of 50 to 75 unit per kg body weight, and recommended 12 to 12 hours interval. In case of the major vessels of the soft tissue hemorrhage, we have to give the 100 international unit per kg, and 12 hours interval is recommended. In case of the mucous membrane hemorrhage, dose of 50 unit per kg, and every 6 hours with the careful monitoring. Severe hemorrhage, CNS bleeding, then we have to consider 100 international unit per kg body weight at 12 hours interval. And the surgery, after surgery or pre-operative, taking care not to exceed maximum daily dose 50 to 100 milligram, international unit per kg body weight should be given at the interval up to 6 hours. So this is immune tolerance induction, factor 8. The prophylaxis monotherapy of 50 to 100 unit per kg 3 times a week. So case continuity, the case third is we have considered patient can be given 90 into 20 weight. So 1800 microgram of the factor 7 to be repeated every 3 hourly till the bleeding stops, mostly for 1 to 3 days. And then we have to consider APCC complex also 100 into 20, 2000 international unit every tail hourly for 3 days or till the bleeding stops. So total dose means dose 50 to 100 international unit of the FIBA per kg. So primary goal to we have to prevent the bleeding. Rule of the thumb is prophylaxis before the surgery. Factor 8 deficiency we have to consider with or without inhibitor imisurazumab. Then the without inhibitor short half-life or the extended half-life factor 8 concentrate, recombinant or plasma whatever the available. And factor 9 deficiency we have to consider APCC complex. So with this, we have a hemophilia center of excellence in our medical college, hospital, and we have a treated total number of 508 patients registered in our institute, and total number of treated episodes 57,400, and council patients episodes of 37,000, and the blood test, and these are the gender-wise 495 males are there, and 13 females also with us. So these are some strategies of our institute. We are treating with the support of the government of Gujarat and India with the rare disease grant. So we are having a center of excellence in our city. So thank you very much for the patient listening and kind cooperation. Thank you.
Thank you so much, Dr. Yogesh, for that lucid presentation and emphasizing that though rare, when we talk about equity and equality, we need to include everyone and not talk only of the common facts. And I'm very happy that the government of India has come out with this rare disease where patients, those who can't afford, they are under the umbrella of rare diseases and they get supported for expensive medications, enzyme supplements, and that was a beautiful way forward. And thank you so much, Yogesh, for that. And I would request you all to now take over. Oh, can we move? I thought this.
Thank you, Doctor.
Hello. Yeah, it's working. So now I invite Professor Dr. Neelam Mohan Madam for her presentation on her own subject, pediatric liver transplant. And she is a beacon in the field of the pediatric gastroenterology in the India and well recognized internationally. Madam is serving as on the post of the President-elect of the Indian Academy of Pediatrics, and we call her as a dynamic lady with the beauty, brain, and with the brilliant idea. So thank you very much, Dr. Neelam Mohan Madam. Over to you.
Yeah, thank you, Adama. Very kind of you for that, and I would start by thanking, they say in our language that when you get to meet God, you need to also see who introduced you to God. So while I'm here appreciating the beautifully organized EPAT, it's extremely responsible for me to thank Sagar, because Sagar and my friendship goes more than 1.5 decades. Sagar, I'm still young and beautiful. But it was truly mesmerizing that I've come here just for 1.5 days, 36 hours, but it was worth all that travel that I did. And I had to, so I'm leaving tomorrow for the commitments, but I guess the title says Crisis to Clarity, and I know you people will be listening in Turkey language, so I'll try to go pretty slow about it. So this is just about my various posts in academics, and I've had more than 250 presentations at international forums and more than 1,200 presentations in the country. And so my objectives would be to talk about an acute liver failure, how different it is in different age groups, and what are the early cues to referring to a tertiary center with transplant, the newer therapies that we talk about, is it just a fashion or evidence and the outcome? Because sometimes in emergencies we do things and then we talk to ourselves, was it just fashion or evidence? So I'll just start with a case, a 7-year-old girl who comes with jaundice since a month and excessive sleepiness for 5 days, irritability and abnormal behavior. So I'm also emphasizing that there was this mistake by the physician, though he did enzymes only on the first time when he met, and he did an INR, which was 1.4, and then the acute hepatitis A virus was positive. The doctor just kept checking the liver enzymes and bilirubin. So that was a mistake because the enzymes were not settling. The parents went to a hospital instead of a physician who was looking after them. And the first thing they do is an INR, which was 4.5. They repeated, it's 5, despite vitamin K. So obviously this is acute liver failure, and they immediately suggested to refer to a higher center with transplant, because this government hospitals in India does not have the, they do not have the facilities for liver transplantation as yet. So there is a change in the definition, unlike in the adults, where you just say that it should be INR more than 2 with encephalopathy. But what we say in children is INR more than 2 without or with encephalopathy, and more than 1.5 with encephalopathy. And this is where we differ from the adults, because in smaller children, identifying encephalopathy is difficult. So this was the international guidelines by the study group in 2000, where both UK and USA, Canada were participants in more than close to 1,000 children. So there should be no evidence of underlying CLD. So what causes it is also different in different age groups. And while we talk about the viruses, still in India, we do get to see A and E viruses in older children, especially Hep A. But when you are looking at a smaller baby or a smaller child, we should remember to do the herpes, adeno, and CMV. And herpes is treatable, especially in the smaller one. So that is an important message that I wanted to give. And you should also remember that metabolic causes are common in children, which could be fatty oxidation, mitochondrial or Wilson's, etc. And the autoimmune liver disease can present to you like a liver failure also, besides chronic liver disease. We often see in a setup like emergency, whether it could be dengue, highlighted by Vasant in his slides, or it could be post-cardiac surgery, sepsis, hypoxia. Often a child can go into liver failure, or an adult, and we should not forget drugs and toxins, whether it could be anti-epileptic, tuberculosis, or other drugs that can give rise to the indigenous use of drugs, especially where you're not sure what they're giving, could be a very important cause. Despite your best of efforts, up to 30 to 40%, you may not know what causes it. So how does it occur? In general, if God was kind to give us not 2 livers, but he gave us more than 50% of the healthy liver. So since it is more than 50%, we just need 35% of a healthy liver, and that's how you donate. And so nearly 50%, I think, should have been really damaged or necrosis before liver failure sets in. And what is it that keeps it going? I think we've heard about bile acids and bilirubin and the metabolite theory about toxins like in benzodiazepines. So we did a lot of studies and everything, but then to make simple things, I think what is most important and easy to monitor is ammonia and lactate. These two can give rise to, these toxins will give rise to brain dysfunction, kidney dysfunction, cardiovascular tone dysfunction, and depressed bone marrow activity. So because of this, then further there is a liver damage and this necrosis sets in. In a simple way, how encephalopathy occurs, that's why I said despite the toxins, it is extremely important to understand the ammonia theory, which gets further worsened by simple things which is in the hand of an intensivist or an emergency physician. The electrolyte imbalance, the fluid imbalance, and sepsis, besides the endotoxins, are equally important in worsening. And if the ammonia crosses across the blood-brain barrier, the brain swells up, glutamate to glutamine. Once it swells up, you know you have a hard surface, skull over it, and that gives rise to further increase intracranial pressure. When there's jaundice with with drowsiness or encephalopathy, anybody can say, oh, it's liver failure. But without encephalopathy, unless you do an INR, you will not, like in my patient example I gave. So these are the early cues where one should transfer early with rising encephalopathy, imbalance, renal issues, hemolysis, bleeding, and a family history would suggest maybe there's a chronic liver disease. Now, this is because a meticulous management can improve. Always important to talk to the person whom you're transferring, because the most important mistake which physicians do leading to a poor outcome is a poor transport. And emergency care physicians should really highlight this, because we need an intensivist anesthetist with a technician and not just anybody who will be able to transfer these patients by road or air. And this patient was then transferred to Medanta, and that is where I work. And this child was drowsy with hyperreflexia. This slide, I'm showing that there's a difference in understanding smaller children. And as you can see in small children, we don't differentiate stage 1 and 2 because insoluble crying could be anything. But this was 7 years, so I would call it stage 3. And stage 3, in the management, I'll go for intubation. Investigations are going to be 2 types, the general and also specific. In a child, you need to see what is the age group, because besides the viral etiology, Wilson's, autoimmune, in smaller, you need to send the other, the TMS, urinary TMS, GCMS. And what I want to emphasize is that we see young adults and adolescents coming with metabolic disorders as liver failure, but the physicians do not understand and appreciate it. And I do get sometimes calls to look for fatty acid oxidation and mitochondrial disorders. So that's a message I would want to give, that you need to remember that the age of presenting of metabolic disorders need not be at the younger. So the cryptogenic that we keep calling are the ones which needs, and with the availability of genetic testing and identifying those genes which give rise to liver failures, we are getting more smarter and smarter. So in this patient, besides Hep A, I would definitely do autoimmune markers, Wilson's marker, because they could be underlying and you need to, that would trigger it. So this is very important to understand the HLH component which happens in liver failure, and you need to be very careful in managing. And in your investigations, look for the lactates, pyruvates, drug, amino acid, acyl carnitine, etc. And the recent guidelines now clarifies it that yes, if in doubt, you can go in for a transjugular biopsy, because we used to shy away from biopsies, but that is a newer guideline which, when needed, you want to do, you can go in because you want to differentiate HLH with liver failure. So I don't need to impress to you all that the circle of care is so very important that you need to monitor this patient not once a day, but like yesterday, the beautiful video we were shown, how you have to just monitor the patient round the clock in the circle with fluids, coagulation, ICP, lung, kidney, etc. What happens if your resident ends up giving little more fluids? You'll end up with a cardiac failure, liver congestion, pulmonary edema, ascites, and increase intracranial pressure with encephalopathy, and you've had it. What happens if your resident gives less fluid? You'll end up with tachycardia, ischemic injury, lung injury, AKI, tubular injury, hepatorenal, less cerebral perfusion. So it is so easily said than done. And what I think we also now do is what you all talk about, the POCUS. You have to have a bedside ultrasound looking at your fluids rather than monitoring the CVP. And though these targets may not mean great, but looking at these targets is extremely important. Keeping your sugars in the right range between 90 to 120. Your sodium is extremely important, 145 to 155, and your phosphate. This is something I always impress on, because the liver needs to regenerate. And for regenerating, I need to be sure that my kinase enzymes are getting their substrate, which is phosphate. So you please ensure that the phosphates are not less than 3, and you need, because that will help in the liver regeneration. So here I am with my patient. The INR is not recordable, more than 200. So we had to put in lines. So we give FFP for the lines and monitor the enzymes. The bilirubin in milligram is 32, and 1 milligram is 17 millimoles. So you can imagine it's more than 300-400. And now, so what is the newer change that we see in the new guidelines is, we used to say protein intake, keep it at 0.5. Now we say you can go up to 1. And rifaximin efficacy in pediatric is unknown. And LOLA, which is the L-ornithine, is not great studies for acute liver failure in children. So one thing I said different was the protein intake and lactulose that we look in. And the optic nerve sheath diameter is another thing we love to do bedside. And the readings are different in children and the older children and younger, 4, 4.5. And in adults, you look at 5.5 plus. So you need to know what is your child when you're looking at the optic nerve sheath diameter, which is really very reliable rather than jumping to a CT scan. This year we came out with our own guidelines in India, and the entire group was involved in this guidelines. And we believe that transcranial Doppler may be useful besides the optic, and the reverse jugular venous oxygen saturation to know the cerebral oxygen extraction could be also a good parameter in using children with the evidence available. And the management is, the mannitol is still the studies which share the first 2 or 3 days. Unless you have renal failure, mannitol is a good option. Otherwise, hypertonic saline and forced hyperventilation burst only when you think your PCO2 has gone high. Routine role of FFP is not there unless you're putting lines. Factor 7 only if you want to put in a bolt. And no studies have shown that the bolts can change the mortality. All that we know is when you want to decide not to transplant, then I need to know what the bolts are for. And AKI, kidney, and this is a lot of studies which are talking about early dialysis. If I think what change I've done in the last half a decade is utilizing early CRT as compared to earlier. We get worried when to transplant, when not to transplant. Will my liver regenerate is the question that we need to answer. Sadly, still a lot of people, we believe in the King's College criteria, but they're not extremely sensitive. They may be more sensitive, but not very specific, especially with hepatitis A. This may not be very reliable, but what are the problems we face despite so many years? And it's a challenge to the Turkey group. You need to do some study, and I would be more than happy. Still, we don't have parameters to decide when to transplant, when not to transplant. Will the liver regenerate? Food for thought for you all. Is a multicentric study would be more applaudable, wherein all this INR, alpha fetolactate, phosphate, factor V, nothing stood the test of time. And I think the reason is we are not able to get an ideal score is so many, the age, the presentation, the etiology, retrospective, missing data, clarification. What am I looking for the outcome? Is it death or transplant or death alone? What is the incorporation bias, the ICU, the blood products, intervention, time point when you're recording? So these are the issues which Basa and Saga need to address. And I was one of the first ones to talk about AKI 10 years back, where I did and said it is time to incorporate AKI in the score with King's College, because we showed that that is more effective. So we know when not to transplant, but there are issues. So look, we are in a center in the East, we do living-related liver transplants. So the parents or uncle, auntie, 18 to 55 years have to donate. Father had a fatty liver, mother liver enzymes were high. We had to support. So while I'm waiting for the donor, this is the newer therapy and not fashion. So there is evidence about CRT, about plasmapheresis, the bioartificial liver support. Mass is expensive, but it removes, it's just a bridge. It removes both water soluble and bound toxin, but studies did not show great effect on that. And rather, I think it has been replaced by plasmapheresis and CRT. The UK guideline says 150 or anything more than 200 ammonia. And when you ventilated and thinking, the plasma exchange is the new baby on the block, which they have shown that it reduces SIRS, SOFA, and CLIP. And as I mentioned, that these parameters will deteriorate the liver. So not only it serves as a bridge, but it may help in the recovery, especially in status where, you know, like a viral etiology, or in conditions like Wilson's, Hep A with hemolysis underlying G6PD, or yellow phosphorus poisoning. So once we kept on for a week, as you can see, from 14th to 20th, doing CRT, plasmapheresis, etc., monitoring the jugular vein oxygenation, NERS, etc., till the mother enzymes settled and she donated. Why was I so satisfied? The satisfaction is her brain was still working. When I asked her name and she rattled her name, oh my God, her brain is working. Because this is where we are worried in managing liver failures. What is the status of the brain? There is no thermometer to look. So now I would like to share with you all the largest study available anywhere on 400 cases of acute liver failure from my center. So there were 392 cases data that I'm presenting. Infections were 47%, which included hepatitis A and E, 80% of this 47, and the others were 7% dengue and sepsis rest. Non-infections, metabolic was 21% in children, which is like Wilson's and fatty acid, autoimmune. And autoimmune was a very small proportion, 2%, but we did have cryptogenic causes overall, 25% or so. So in the others, I included drugs and cryptogenic. So 3/4 in the 32% were cryptogenic, and that the overall outcome was good. Spontaneous recovery was in 67%. So what I'm highlighting is a good medical management can salvage 65%, which is not in the data, not in literature. The reason is hepatitis A was common, and hepatitis A, while if the liver regenerates, we can conquer over it. So we did liver transplants in 25%, and 10% or 11 had refused or died, and 65% recovered. So that is my liver transplants for infections 27, metabolic, autoimmune, and there was a survival of close to 90%, which is extraordinary high because we are living related center. We've come a long way. I salute this mother because this was my first child and the first in India where we did liver transplant in an acute liver child in 2004. And since then, that handsome boy is on the other side, was talking in one of my conferences about it. So I'm truly humbled to be the right person at the right time in the right place in India, where our team has a lot of milestones in India. We were the first to do the cadaver transplant. We were the first to do the liver failure, which I just showed. First combined liver, kidney, first swap transplant, first robotic donor transplants, first blood group in matching transplants, hepatopulmonary syndrome.
Dr. Neelam, we are exceeding time. So.
Yeah. So the hepatopulmonary and the lightest baby, this was the combined liver kidney, and domino transplant is where you can give a part of the liver to another child. That's called domino, because the other enzyme is normal. These kids grow, and I think I'm humbled that in the world, the first factor 7 deficiency who was saved was in our center. This boy was bleeding, and we did a liver transplant to save him by monitoring with the tech machine, and the world's lightest baby, 2.16. The baby is just in my hands, as you can see, so small, was also salvaged. And this was another swap along with domino, which became the world's first chain. So these children are very challenging when they are small, but we have a story of more than 50, 20 years. The babies who are holding the babies are not the one whom I transplanted, but the mothers were the one whom we've transplanted. So the survival is good, but the important to understand is that we need to support the liver with small little things which we forget: the electrolytes, the fluids, the phosphates. These are the ones which actually is in the hand of the physician, which can change the outcome, and you need to monitor them, not a day. They are the one who need continuous monitoring, safe transport, safe care, early CRT, early plasmapheresis when needed. These are very important, and transplant in a living related is extremely satisfying. I'm grateful to have received the award from the President of India for starting liver transplants in India. And I acknowledge all of you that we have a very good setup of training. We have around 6 trained in transplants, and people from Africa, etc., come to our center to learn at a very cost-effective, just $27,000 to $30,000. That's it. Thank you so much, and do follow to hear more.
Thank you, Dr. Neelam. Really, it's her passion, that the gastroenterology and that liver transplant and treating liver, it's her passion. That's the only thing. She's doing only that. And that is a great thing, great she is doing. And really, you could assess that about looking at her and watching her presentation, that what's the amount of work she's doing. So many things that since beginning, she was, I think she made for that liver only. I think not for her family also. She compromised family also. And really, it's a passion of her. Thank you once again. Thank you.
Thank you, and that's truly humbling to hear from you. Dr. Vasant is like a spider who keeps doing it and ensures he gets what he wants in life. Thank you, thank you so much.
Because of time constraint, we should sum up this session. We will end this session. Is that? Yeah. Yeah. Sure. Thank you.
Any questions, any queries from anyone?
Oh.
The rash and
That question.
sexuality.
Yeah.
नहीं वो सबको नहीं रैश भी बहुत अच्छी थी ये लोग तो नहीं देखते होंगे इतना
Thank you very much, Professor Vasant, Yogeshi, and Mohan, for this very nice section. I was very happy to be here listening to you. I get very huge benefit. My first question is for Dr. Vasant. You know, the rash, there are so many different kinds of the rash, and they are very huge similar to each other. It is mentioned there about 30% of the population are pediatric, and usually the patient who come to emergency department rush, they are pediatric patients. So my question is that what is the credibility and reliability to use artificial intelligence for diagnosis and for treatment? What do you think for this? And then, secondly, what do you think about the VIV consultation? Sometimes we get the photo and send the consultant. What do you think about it? We will get the photo of the patient and send the senior or the consultant patient for diagnosis. To Yogesh, my question is that you mentioned that the percentage of the hemophilia patient in India is about 8 and 10. Whereas we look at the population, your population is about 17 or 20 of the world. There is a discrimination here. What do you think about that? And thank you very much, Professor Mahan. When you started your speech, I got a note. You presented over 1,200 presentation. Initially, I had a suspicion. I noted it. When I listened to you, I said, okay, that's okay. Thank you very much. Yes, thank you very much. But do you think that you have a delay for your patient? Because your patient admitted to emergency department and 27-18, and you transfer the patient at 11, 12, 8 and 8. So I think there's a delay for here. And thank you very much.
Yeah. So your first is that using an artificial intelligence, AI. I think so. But my presentation was that about our program, that are symptoms and clinical clues. So here our knowledge is very important. Our clinical knowledge is very important. It's a correlation. This whatsoever maximum cases I presented, it's without any investigation and without anything. That's here as a physician, our role plays. Second, to see the picture and going to diagnose it, it's a little bit difficult. I think so. It's very difficult. Something like you can't examine the patient. Suppose the patient come with that's why it's not a viral exam. It's a fever with rash is not only a viral exam, it's a beyond. So just looking at the rash, it's a purpureal rash, I will say erythema nodosum, and then that to be turned up in a meningococcemia, that can be the thing. So I will not believe that looking at the picture we can diagnose. It's very easy. Like suppose it's you diagnose it as chickenpox, and initially initial presentation is like a chickenpox, and that turned to be meningococcemia. What you can do? You will be blind, and nowadays you know how the people can sue you and everything. That's why I don't believe in that AI and by photogenic diagnosis.
One of the things I want to iterate, we are doing the largest AI study for appendicitis in America, right? So yes, they have come to a conclusion that AI can effectively diagnose appendicitis. I see that craze also in Turkey. So last year when I was at EPAD, there was a team who was, I don't see them this year, but last year they were there, where they say that you don't need a doctor to diagnose appendicitis on CT. So one thing I'll tell you, the smartest radiologist in the world, when they send you the report, they write one line below. Clinical correlation is needed. Yes or no?
Yes.
So they put the blame on you right away, number one. Now you are saying that you are going to allow a human to leave that blame game and give it to a AI and then tell it to you. So I'll tell you the after effect of that. AI software is put into the radiology software. You are getting the result. Radiologist is saying this is not appendicitis. AI is saying it is appendicitis. What will you do? No, this is a very crucial question.
Can I take that
Yeah.
with permission to
So AI says this is appendicitis. The radiologist says it is not appendicitis. Doctor is saying this is not appendicitis because the clinical exam CT was done because abdominal pain. We don't know what will y'all do? No. Think 1 minute before you give us answer at your spinal level. AI has said it's a certified AI software implanted by your hospital, certified by the insurance company. Will you go for MRI? Will you go for admission? Or will you go for surgery? Or you will say, I believe myself this is not appendicitis, and ready to take that risk on your head. Admission, okay.
Well, actually, I would put it into two things. One is for your question about AI. AI will definitely help us, definitely, but what you need to give the information to them is, what Vasant was saying is only pictures may not be useful. You need to give a little more information about the history and the other parameters that might affect. But I think AI would be useful a lot to assist us in that. And to answer his question, now, appendicitis means inflammation of the appendix. Now, inflammation of the appendix could be due to so many reasons: infections, constipation, typhlitis, etc. So when I say appendicitis, when to operate on an appendicitis is the question. So even if there is inflammation of the appendix, which say normally would be 2-3 millimeter, it goes up to 5.5. We've seen up to 6.5 we don't operate on, because there is appendicitis, but it need not go in for a surgery at that. So the eyes of the AI was so good that it detected that there was a swelling which the AI identified in the appendix. But that doesn't mean the patient needs to go for surgery. It doesn't mean that as I said, it could be due to so many other reasons. You need to put, and that is why the beauty is, we human beings could not replace God. So we got a machine to help us, but we can't replace the God's machine, and it is you who are going to interpret that machine. But there are data, there is evidence on that there was a scan wherein the AI said that there's going to be some breast cancer, something like that, but it was not seen clinically and in other imaging, and that lady later on follow-up turned out to have. And the AI detected it much better on the mammography while nobody did. So the teaching is that you can't just throw away what the AI says. You need to follow this patient, and I endorse the lady who says probably monitor whether you observe, you admit, or you follow up. So I endorse you, but you cannot say it's not there. And I have not done surgery for children with 5.5 to 7. If I don't find tenderness, rebound, guarding, rigidity, I wouldn't. But depends, is it in obese, non-obese, so many other issues.
Thank you very much. I completely am with you. The physical examination history is okay. There's no any change. This is not a recommendation, just a question. So you know it is discussed. But the example that you gave is different, really very different. Appendix is really different because this is dependent to radiologic images. But rush, they are very similar to each other. That's why I asked this question. By the way, you mentioned about the retinal diameter measurements. So you said if it is more than 1.5, this is in science of the encephalopathy. Do you think it's a delayed symptoms? If the patient has a large diameter of the retinal, so it could be a delay.
Right. So when we diagnose, the million-dollar question is that you need to understand what is cerebral edema. But every patient with cerebral edema would not need a transplant, but they have poor outcome. You can have encephalopathy with cerebral edema, encephalopathy without cerebral edema. Your CT scan images may not detect cerebral edema, it may not be very, but even if you detect yet the patient. So transporting a patient all the time for scans to detect cerebral edema is not what was. So this optic nerve sheath diameter is a beautiful bedside test, and it was in adults that it came, where they set the cutoff of 5.5 millimeter. Then a lot of studies went in children, and the cutoff less than 1 year is more than 4 millimeter, and more than 1 year is more than 4.5 millimeter, but in adults it's 5.5. And I feel that it's a very useful modality to detect, and you need to just start with your anti-cerebral edema regimes when you see that. And I feel that the reason for success in a good setup is where you literally need to not only have 1:1 nursing, like people afford 1:1 nursing, but time has come. If you want a good success rate in liver failure, I literally say that you need 1:1 doctor or 2 doctor, because our liver ICU, I have 1 doctor who does not see the other critical care. And how many do you have? 1 or 2 at a time, or 3, including transplants? So the care increases a lot, and that's how the outcome improves. And it's just a short time. That time you have to be vigilant, otherwise you've lost it. The window period, like in pancreatitis, like anywhere, the window period, that's extremely important in liver. And we can look into those studies with that.
Sir,
You asked for...
yeah, regarding, sir, the data we presented, more than 2 lakhs global hemophilia patients, and out of that, 21,000 in India currently. So it is nearly 10%.
He means of the global.
Globally.
But almost 25% of the children globally live in India.
Hi, first of all, thank you to all for these great presentations. I have a question to Professor Parikh. Of course, I think the most important thing is to detect the carrier of hemophilia and to protect the next generations. But in my clinical practice, the GAN therapies results are so nice that I have some patients and they got too many factors and they had some complications associated with hemophilia. Parvovec, I think the name, I looked Roxa Parvovec or Deza Parvovec, I couldn't remember the name. The GAN therapy have good results, especially in İzmir, Ege University. What do you think about in children? Because in adults I have some experience that the GAN therapy has very good results, but is it the same with about the children?
So what is that? Is it a drug that you're talking about?
Dr. Parikh, hemophilia for GAN therapy
So
for
the new thing which was tried in adults is what?
what? Again?
What is the name you're asking?
Roxaparvovec and Dezaparvovec. They had 40 patients. Some of them was my patients, I know them, and the results were satisfying.
Yeah. So you mean to say in the adult cases?
I think their group was consist of 40 patients, and a couple of them was my some of my patients and my familiar, and the admission numbers was decreased to treat factor therapy or to admission to the emergency.
Which drug he is asking? For the adult cases, he is asking some. Question में समझ नहीं आया.
And Dr. Parikh, what do you think about GAN therapy in pediatrics for hemophilia?
He's asking gene therapy.
Gene therapy, yes.
Gene
So
therapy.
yeah. So I told about what is in the hemophilia A and the hemophilia B, both the cases I told regarding this, in case of this hemophilia A, what you mentioned, the drugs, but in the children still we are not, in the India we are not come. Yeah, so we are not, in the children we are not applying that.
Not same with adults,
Yeah.
I think.
It was, I think, approved FDA only in December 2024, if I'm not mistaken, because I remember reading that the therapy got approved in adults moderate to severe hemophilia in
Yes.
the end of, brilliant question, end of December 24. Yeah.
Yes. The same study that I
Yeah.
talk about.
So gene therapy approved FDA, but we don't do it, right? And but it's a good question, food for thought for him.
Thank you.
Thank you. Let's have a picture together with the whole.
सागर आपके साथ फोटो
and welcome to our panel. It's a great honor to be with you today in our hot topics. And I would like to invite Professor John Ma for their presentations. The new textbook idea taking a concept of publications, editing the ABC of the textbooks. As you know, John Ma is a very famous emergency medicine professor. He has got at least 5 chief editors of the famous emergency medicine books. So, thanks for you. Let's start.
Thank you very much. I'd like to begin by thanking the scientific and organizing committees for inviting me to speak at this Congress. So in 1994, so 31 years ago, I was finishing my 4th and final year of my emergency medicine residency at the Medical College of Wisconsin in Milwaukee. And I applied for an open faculty position at the University of North Carolina in Chapel Hill, North Carolina. Dr. Judy Tintinelli was the chair of emergency medicine then. She had been hired 2 years ago as the inaugural chair of that newly formed department. I now know that there were dozens of people who applied for that one open position, some very well-established and well-known physicians. And for reasons that are still beyond me, Dr. Tintinelli decided to hire me for that spot. And so when I arrived in Chapel Hill as a brand new attending physician, as an assistant professor, I made it my mission to work as hard as I could for her to prove and to show that I deserved that position. So I worked very hard clinically. I taught, I won teaching awards, and I performed a lot of research and published papers. And in 1996, Dr. Tintinelli and I decided that we wanted to publish a brand new textbook that was sort of a handbook, a manual, that was a smaller version of her authoritative reference textbook, Tintinelli's Emergency Medicine, a Comprehensive Study Guide, that had been well established and was sort of the gold standard for emergency medicine textbooks. So I was lucky enough to have been selected by her to help edit that textbook. And that's the success of the Manual of Emergency Medicine led to another textbook called Just the Facts in Emergency Medicine, which I helped co-edit. And that was designed to help physicians study for the board exams in America. So ever since then, up until today, I have now been lucky enough to have published 20 textbooks in emergency medicine that have been published in 10 different languages around the world. And so I am here today to help share my experiences. I think developing a new idea for a textbook is just a very, very exciting thing. And I think many of you sitting here today have ideas for a textbook that you would like to develop. And I'm really just here to help share my experiences and help guide you and offer any advice I can. So the objective of my talk is just to give you an overview of the process to develop, propose, and market a new textbook, because we know this is a very, very competitive field right now, and developing and proposing and marketing this new textbook idea requires a very strategic approach to the process. So to start off with, when you are thinking of a new idea, the first thing you really want to do is to analyze the trends in that particular field. So what would really make your new idea sort of unique and special? Why would a publishing company want to publish your textbook? So the first thing to do is take a look at what's out there right now. You know, what are the existing textbooks, and what are their gaps and their weakness? Because I can tell you, every single textbook has a weakness and some gaps. So try to look for something where there really needs to fill a gap in that particular area. The next thing, and one of the most important things, is identifying that target audience. You know, what is the subject and who are you really aiming your textbook at? Is it really at seasoned practitioners or novice practitioners or students or both? And I'll come back to this a little bit later, but this is a really key question, is who is exactly your target audience and why would they want to purchase your textbook? So next thing is really identifying what we call the unique selling proposition. How is your textbook different from the competitors? You know, how are you going to fill in the gaps? And what special features are you going to add? You know, will you have a digital supplement? Would you consider some interactive elements, case studies, videos, and so forth? Now here comes the hard part, is really trying to develop the content. And you really need to think about what are some of the key concepts and topics that you want to cover. The outline and the scope and the objectives really include the topics in the table of contents and really develop that framework for the textbook. Writing and editing is going to be probably the most challenging part for you. And the first thing you want to do is think about drafting a chapter, a sample chapter, and take your time, work really hard on what the chapter is going to look like. What are some of the sections for that chapter? What are some of the subsections? The other thing is you really want to make sure that after you write your chapter, to run it by some subject experts in that field to make sure that it is completely accurate. There is nothing that will torpedo your project more quickly than to have inaccuracies in your chapter or in your textbook. So collaborate with the other editors on your project, think about refining the content, make sure everything is accurate, and know exactly what you want to include. The next part is really fun. It's writing the proposal. And this is something that you're going to want to obviously submit one day to a publishing company. So the first thing is the title. Think of a very jazzy title that will catch people's attention. The second thing is a table of contents. That will, of course, evolve with time, but really come up with as detailed a table of contents as you possibly can. Then you've already written your sample chapter. Maybe have 1 or 2 or 3 chapters that you can use as sample chapters. Now you look for the market, see what kind of data is out there, research, and think about really what other textbooks are selling and how well they're doing in the market if you can find those data. Finally, you're going to want to ask your co-authors and your co-editors for their credentials and come up basically with a mini CV for each of the co-editors so that you can show the publishing companies why you truly are an expert in that field and why they think that you are someone who would be really good for publishing that textbook. And then finally, come up with a rough timeline that you can offer a publishing company. Now you want to find the potential publishers who would be interested. So start researching publishing companies that have a history of publishing textbooks in your particular field. Try to align your proposal with their focus and their vision. And ideally, go through social media, perhaps Google or LinkedIn and things like that, and try to find a contact person, ideally at that publishing company, that you can reach out to and sort of run your idea by them and get their feedback in a very informal process while you are developing your proposal. It's really important to select the right publisher. So there are many who are very focused on scientific and medical and academic books. In America, for example, we have Elsevier, Springer, Wiley, McGraw-Hill. There are multiple European publishing companies, multiple ones in Asia as well. So do some due diligence and get your research on who you really want to submit your proposals to. And check their submission guidelines on their websites or talk to the individual. So now you've established your proposal, you've found the right publishing company that you want to target, so go ahead and write a professional email introducing yourself, the book content, and attach your proposal along with the sample chapters that you've worked hard at. And then wait, and hopefully, they'll come back to you. So let's just say they are excited about this project, they really want to move forward with it. Now it becomes another fun part, which is negotiating with them on discussing the terms, the royalties, the copyright ownership, and then sort of understand the options for print versus digital, and just be very, very flexible with this. Try not to be so stuck with your proposal that you feel like yours is really the only way to go, because the publisher is going to have some ideas on how to change things, and be very flexible, entertain their ideas, make changes, and be with that, and don't be that person who says no just because they want to tweak a few things. So again, be very flexible here. And once everything has been established, you've written the contract, everything is signed, now you get to market your textbook. And again, this is a very fun process. Work with the publishing company on strategies to promote and maximize the exposure for your new textbook. Work with their marketing team. They're going to want to see what ideas you have. These are marketing people, but they're not physicians. So they're really going to be interested in hearing from you, and you're going to learn a lot about marketing from them. So it's a fun process, and it's a very interactive thing. Contribute to their promotional materials, through websites, blog posts, and things like that. And again, find that target audience. Are you going to attend a congress, a scientific congress like this, to market it? Or are you going to go to medical schools? Or are you going to go to professional society places like ACEP or SAM and things like that to help market your textbook? So I've covered sort of the nuts and bolts of coming up with the concept, the initial idea, all the way to marketing the textbook. Now I've come up with 7 common pitfalls and errors that not only have I seen, but I've done myself. These are errors I've committed, and these are errors that my publishing company, McGraw-Hill, has shared with me. And so I'd like to help share some of my mistakes with you, and hopefully it'll save you time down the road. So error number 1 is coming up with a weak or unfocused proposal that may result in the rejection of your idea. So the publishers are looking for a very, books that have a very clear potential for sales. And this shouldn't come as a shock to you, but we think that the publishing companies are out there to, help us, all of us learn. That is true. They do want to send out educational materials, but their number 1 goal is sales. How can they make money from your idea and from your book? So help them with the sales part and come up with that clear proposal. So the solution for this is, when submitting a proposal, ensure that it's well organized and clearly presents the textbook's unique selling points, as I mentioned earlier. Error number 2 is lacking a clear target audience and not really defining who you're intending your book for. I touched on that earlier. Are you looking to publish your textbook for seasoned veteran physicians, residents, medical students, pre-medical students? It's hard to do it all, and I've tried that before, and it just doesn't work. So you really need to know your target audience and really focus on them, and try not to be the jack of all trades textbook, because that just isn't going to work, and the publishing companies will really see through that and reject your proposal. Error number 3 is overloading or underloading the content. You know, sometimes providing too much information may overwhelm readers, or too little information may leave gaps and weaknesses in your textbook. So really find that right balance of not too much and not too little. You know, we've done that in our textbooks, especially with topics like toxicology. You know, some of the toxicologists will go into some really, really minute detail. And that's great if it's purely a toxicology textbook, but for a general emergency medicine textbook, a lot of physicians aren't really interested in the ATPase and pH, systems that we all learned in biochemistry. So we just want to be careful about not adding too much detail that may lack interest for our readers. The next error is the failure to differentiate yourself from competitors. So that's where, doing that initial marketing research is really, really important. Trying to create a textbook that doesn't offer that unique advantage over existing textbooks will make it very difficult to sell, and most likely because of that, the publishing company will reject your proposal. So really take the time initially to conduct that competitive analysis to identify the gaps in the current market and see where your textbook can be truly unique. The next error is the inadequate research and fact-checking. Presenting outdated information or incorrect or poorly researched information will really severely damage your textbook's credibility. There's nothing worse than when things get out. And now with social media, with the internet, if there's an error, people will make that well known very, very quickly, and it'll spread like fire. So really take the time and go through it with a fine-tooth comb, go through colleagues, peers, and make sure that the peer review process is very, very strict for your edits, because you don't want to risk any errors. And finally, overlooking any digital integration. I think, we all love reading a textbook, but now in this day and age, we really need to supplement the print aspect with a digital component. So ensure that your textbook proposal includes a digital presence and a digital component. We say a picture is worth 1,000 words. Well, a video is certainly worth 100,000 words. So if you can have videos like some of our lectures yesterday, the videos were very compelling of some of the trauma resuscitations. Let's include those videos, because those are excellent for teaching and will really supplement the written component. Oh, and finally, the last error is ignoring feedback from your peers. So make sure that you take the time to listen very, very carefully from your peers, your colleagues, when you send this out, and be open to feedback, not only from the peers, but also from your publishing company. Don't be that person who's so inflexible that you will submarine your project because of that. So in summary, some of the key takeaways are developing, proposing, and marketing a textbook requires a lot of collaboration, creativity, and continuous adaptation. Be very persistent. You've seen stories about some of the greatest novels out there have been rejected multiple times by publishers. Same here with medical publishing. Your proposal might be wonderful, but it might just not be the right fit for a particular publishing company. So be persistent. Don't be swayed by just some negative comments. Go out there, stay positive, and keep submitting it until you find the right publishing Stay flexible, avoid the 7 common errors that I mentioned, and most importantly, remember, understand the needs of your target audience. That is probably the most paramount thing. I'm going to be around for the next couple days, and I will be delighted to talk to you about any ideas that you have for a textbook, and I will be happy to share any insight that I have into helping you launch your proposal. Right after this, I need to run upstairs to watch one of my residents give her scientific abstract oral presentation. So unfortunately, I won't be able to stick around immediately after this, but I'll come back after she's done, and I'll be around all afternoon and then for the next 2 days. So thank you very much for your attention. Appreciate it.
Thank you very much for your presentations. You basically summarized the main principles of editing a textbook. Thank you very much, Dr. Jonma. Have you got any questions? Because we have a different topic at this hot topics. Have you got any question from the audience? Yes, Dr. Behçet.
Is there a phone? Is there a floating microphone?
Thank you very much. I'm sorry, I could not be able to listen to all of your presentation, but my question is that you summarize everything about the writing preparing. The question is, I just want to carry your point to another option, is that how could you be able to consider and provide the balance between writing the book and publish it as hard copy or digital system? So, for example, we have a friend, he's very familiar, is publishment. He's published our books. But now, today, we know that also the digital system cannot be controlled. And you gave a very huge effort by writing a book. It is not very easy. So how can you consider or provide the balance between publish it as hard copy paper or put it in digital system?
Well, I think in this day and age, digital is definitely the way to go. I mean, it will get out there faster than a print edition. Even when you finish the print project and all the editing is done, it still takes months and months for the publishing company to actually print it, put the hard book, and then send it out to the bookstores. Whereas with digital, all it takes is hitting the button and it goes on live. So I think coming up with the right combination of both is ideal, but really I think digital is probably the wave of the future right now.
Maybe I have gotten another questions for me. Have you got any, did you experience any funny memories about your books you edited? Or, maybe interesting points you mentioned? Because, you're the chief editor for many emergency medicine books. Yeah.
I mean, I think fun is just really, the most enjoyable part is working with the authors of the chapters. We have a lot of funny stories where, people, might misspell something or have an error, and then you correct it and we kind of laugh about it. I don't know, it's just more just the fun of interacting with people and meeting new authors of the chapters. I think that for me is the most entertaining part. And then probably the worst part is just the time it takes. The very first ultrasound book I still remember was published in 2002, and I spent most of 2001 working on editing that textbook. And the reason why that date stays in my mind is because my son was born in May of 2001, and to this day, it's sad, but I don't have a single memory in my brain of actually holding my son. There are pictures. My family has pictures of me holding my son and feeding him and doing fun things. But I don't have any memories of holding my son because I was too busy, doing my regular job as an emergency physician and also my free time editing textbooks. So I think that's the downside for me.
Thank you very much.
Oh, there's.
Sorry. I have two questions. The first one, as you mentioned, you would be contact with academic publishing company before write the textbook, right? What's the advantage of contact with them before write the textbook? What's the advantage of contact with the publishing company before write the textbook?
Yeah, the publishing company, it's, you want to make sure that your goals align with them. So, spending the time to write the proposal and finding that company, the right company, before, going too far. You don't want to spend too much of your own personal free time coming up with this large textbook before submitting it, because who knows if they might like it or not like it, right? So I think just coming up with one or two chapters and working with the publishing company is probably the right balance.
The next question, I authored a book in Arabic on emergency management, and that sold very well in northwest of Syria. My question is, what is the best way to address this issue to another language on publishing company?
Another language? You saying it? Translate from one language to another.
From Arabic.
Yeah. You can work with a publishing company. They will do that for you. So write the textbook in the language, your native language, and then work with that publishing company to get it translated into whatever other languages are out there. Because everyone will do their best work, obviously, in their native language.
Legal allowance. We need legal allowances to translate and use this textbook.
Allowance?
Legally.
Legal?
Yes.
I believe so, yeah.
Ah.
Thank you very much.
Thank you, Dr. John. Now I would like to invite our second speaker. She is particularly known for her expertise in simulation scenarios in the ED patients and has a significant research in this field. I would like to invite Professor Fatima Latif to the stage to give her presentations entitled The Science of Simulation Research. Dr. Fatima is from Singapore.
Thank you very much. Good afternoon, everyone. And it is indeed my pleasure to be here in Turkey to share with everyone. I would like to thank WASEM and also EPAD for inviting me to share at this conference. And I will have no conflicts of interest to declare. And the research that you will see here are all published with no conflict of interest, and only educational grant funding has been utilized, essentially. I am a professor of emergency medicine at all the 3 medical schools in Singapore. I work at Singapore General Hospital in SingHealth, which is the largest teaching hospital in Singapore with 1,800 beds. And we are an academic medical center, and we have a full-fledged simulation center, which is the largest in Asia and the most comprehensive facility. I'm here to talk to you about the science of simulation-based research. Science refers to evidence-based and a systematic approach to simulation-based research. Now, if you consider simulation, well, the state of development has been relatively new, a relatively young discipline, but it's getting more and more popular these days across the spectrum from students all the way into faculty development. Well, if you go on to talk about simulation research, it is even younger than that. And not many people are familiar with what is simulation research, because everybody thinks that using the mannequins to teach clinicians and students is basically simulation. But there's a whole big spectrum of simulation, from using task trainers to low fidelity, medium fidelity, high fidelity, AR, VR, serious games, mixed reality, and a whole lot of technology-enhanced learning, which really is all simulation. So therefore, if you're thinking about simulation research, essentially, I like to categorize them into these three categories, which is simulation-based interventions, where you really use simulation to try out skills, upgrade and upskill, as well as even implement new techniques, pathways, and protocols, test them out by using simulation-based research. Secondly, it is linked to education and training interventions. And of course, all of you are quite familiar with this, where you will learn a lot of new things in the area of knowledge, skills, and attitude, the KSA development, and also training into deliberate practice, where you can practice again and again until you reach mastery. And all this can be translated into research. And again, the final category I like to share is the investigative simulation, where you can compare the old way of doing things with the new way of doing things. And of course, there are many, many different things that can be developed from this. So simulation-based interventions. I'll just share with you some of these papers, because a lot of people are not familiar how they can write qualitative and descriptive research in simulation and publish papers. Because if you want to get promotion, if you want to be an academic department, publications is certainly very important. So in 2019, we came out with a WESM expert document on hybrid simulation, where you use 2 or more modalities of simulation to actually teach different variety of topics. And this has become a landmark paper where a lot of people actually communicate with me in trying to use hybrid simulation. And one example of hybrid simulation is when we want to teach emergency department thoracotomy. Because as you know, we only will get 1 or 2 cases a year in most emergency departments, and therefore the residents may not have enough exposure. So therefore, developing a model using a standardized patient or a volunteer on the model, we actually can teach this. And this is tested through simulation-based research. Again, during COVID, we actually developed this device that you see here, which is actually protective and negative pressure, and we can actually put our hands into the 2 gloves and take the swab, and then, you know, it protects the healthcare provider and the doctors. And again, we tested this with simulation-based research. In situ simulation to plan malignant hyperthermia protocol. Well, malignant hyperthermia is not common. It is very rare, but we have to be prepared, and we have to have a high index of suspicion to diagnose it. So therefore, in actually coming up with a workflow with the box for malignant hyperthermia management, with all the dantrolene and all the other things that we need, and the cue cards as well, we actually use a lot of simulation-based testing in the in situ form, and we have, of course, formalized the management using this. Again, if you're using multi-casualty trauma scenarios for teaching, you can use simulation-based research. And again, this is quite qualitative in the sense that you can describe what you do. When you share, people from around the world will be able to actually get the idea of how to do this, and they might actually contact you for collaborative research. Again, in emergency medicine, we are very, very unique in the sense that we are at the center of interprofessional care. We work with almost all different disciplines in the institution. So therefore, how can we enhance and uplift team-based practice, and using in situ simulation and interprofessional simulation, we can actually conduct a lot of simulation-based research in the emergency department and look at how teams perform, how to train high-performance teams, how to use deliberate practice in simulation to uplift the performance of our high-performance teams. Now, there was a period of time when we had quite a bit of errors when our nurses were doing infusions in the resuscitation room. For example, we have to have noradrenaline diluted very quickly, or any other drugs like GTN or IV insulin. And for the young nurse, they might make the error. So therefore, to correct this problem, we used simulation-based research where we developed a serious game for the new nurses and the new recruits to play this infusion game, and then they are familiar with it, and they only come for a very short period of face-to-face infusion setup learning, and then, they are much better, and they master this a lot better, and we also can reduce the contact face-to-face time for training. So that's good for everybody, and we had very, very good feedback for this. Debriefing serious games, if you are not used to doing this, there are different ways of doing this, different techniques, whether it is incorporated into the computer-based game or whether you want to have a faculty do it after they play the game, that's also possible. So these all can be research ideas. Now, when we have medical students come in to do simulation, you find that just putting them in the sim lab and doing a terminal debrief at the end is not good enough, because unlike the doctors, they may not be familiar. So therefore, we introduced the concept of micro debrief for our medical students. That means the faculty, instead of standing behind the one-way mirror, goes into the sim lab with the student, watch them, can stop the simulation at strategic points, brief them and show them what exactly to do, and then you can repeat this again and again. It might be a bit disruptive for the advanced practitioner, but for the students, they love it, and they gave very, very good feedback, which was statistically significant, and so now we are using micro debriefing technique for all our students. We did this with progression of our ACLS course into the hybrid version, and with acute care medicine pathways. And also this is another landmark paper where we talked about simulation-based learning, which is quite similar to filmmaking. Quite an interesting paper. For those of you who are interested, you can read this. And some more papers on setting up a simulation center. And you don't always have to have expensive equipment to have a good simulation center. The fidelity and the equipment you have need only be as high as you can get your learning objectives across to your learners. And we also have other research such as the novel CPR device. I won't elaborate too much, but I hope that this sharing will give you some idea of what simulation-based research really entails, and I hope that some of you will be inspired to do this, as you move away from the conference. Now, in the educational and training intervention, we had a lot of this during the SARS and COVID periods, where we learned about infectious diseases, how to transport patients in a safe way, how to use negative pressure rooms, how to use implementation science in our in situ simulation, and make sure that our pathways and protocols work very well, for example. Now, when it comes to debriefing, we are quite different in terms of our learners' response from the West, because Asians in general may be less verbally conducive when they speak and share their experiences. They may not talk so much, and so on and so forth. And Turkey may have part of this culture as well. So therefore, we actually tried out different techniques to make our learners talk more during debriefing, and so we shared this in some of our papers as well. Now, everybody is very concerned about the psychological safety of our learners today. And this has taken a big uplift with COVID-19. Everybody is concerned about the psychological safety of practitioners, of learners, and healthcare providers. So therefore, we actually try to see how we can improve the creativity by making sure that, the simulation-based activities maintain psychological safety. We've come up with mnemonics and different ways of maintaining psychological safety. computer-based simulation for students, very, very popular, especially when we had COVID. And this was because they couldn't come in to the simulation center. And so we use a lot of modalities on the computer to teach them how to manage cases with simple scenarios, with airway management, circulatory management, and also full scenario management. And it was very, very popular with the students. Now, the other thing about simulation is it has so many spin-offs. Even mental rehearsal and scripting is a kind of simulation where you go through in your mind the steps that you have to take in doing certain procedures or managing certain scenarios. And again, we tested this out with simulation-based learning and published a paper on that as well. In the area of AI and technology-driven education, we must not forget the elements of humanism. So therefore, we always have to make sure that patient is really at the center of all the things that we do, and our learners must also be at the center of any educational strategy and intervention. The use of big data, where we simulate this, how we actually apply big data to a lot of settings in our clinical context, the use of standardized patients in Asia, because this could be slightly different from what is common in the West, for example. So there are certain unique considerations that we found, and certainly these were very valuable findings as well. Now, in the area of investigative simulation, where we can compare and contrast and develop new ways of doing things, we actually used it quite a lot in the in situ way, and we also use the failure mode effect analysis of quality intervention as we uplift our clinical pathways using in situ simulation. For example, this paper is about how we actually use simulation to actually uplift the way we activate our neonatal emergency obstetric code for any maternal cardiac arrest. And we actually worked across the discipline, emergency medicine, obstetrics and gynecology, neonatologists, and also the operator from the call centers, for example. They were also involved in the simulation, and our security officers, because they will help in the transporting of the open care system into the emergency department. So all this is multidisciplinary, interprofessional, very, very useful form of simulation. Now, sequential simulation is another area where you can use simulation-based research. Sequential simulation means that you do it in a sequence. For example, as the patient is delivered to your emergency department from the EMS or from the ambulance personnel, and then they drop the patient at the resuscitation room and we manage them, and then we activate the emergency operating theater and they will then do the surgical intervention. So that's sequential from one location to the next, and that's also something that can be practiced well with simulation. And we share our experience by publishing papers, for example. Now, one of the latest papers is actually on the trauma code. And this is something that we worked in Singapore with Florida, with Dr. Saga Galwanka, and we did simultaneous simulation, one team in the US and one team in Singapore, where we came out with a scenario managing a patient, just one patient, who has both neurological deficit from stroke and also sustained trauma. Often when we manage trauma patients, we know we can use ATLS. And when managing stroke patients, we can use the NIH scale. But when you have one patient with both these conditions, sometimes the management can become haphazard, and because there's so many things to look into. So we came up with this trauma code, and this paper is likely to be published in the next few days. So look out for it. It will be in the Journal of Emergency Trauma and Shock. So therefore, there are advantages of doing simulation research, and a lot of it can actually be sharing experience, qualitative research, thematic analysis, descriptive sharing, and it can be slightly different, but it can also use the normal research methodologies. Of course, there are advantages and disadvantages like any other forms of research. So, you know, with simulation-based research, you do not hurt any patients. You can repeat it again and again. You can have deliberate practice. You can actually look at individuals, teams, performance, and even larger scale. You can look at it sequentially. You can conduct it outside clinical hours in the lab as long as you have time, and so on and so forth. And if you do have a simulation center, this is certainly an asset for you if you are considering simulation-based research. Of course, there are disadvantages. For me, I am a strong proponent of simulation-based learning, but there are people who are skeptical about using simulation-based learning. Well, so therefore, we may need to convince them. You may need to have champions who can share the ideas across your department. And of course, not all scenarios can be replicated. For example, when we were doing the Stroma code, neurological symptoms cannot be depicted on a mannequin well. We had patients who were standardized patients or volunteers who actually have to depict, the hemiplegia symptoms, for example, not moving one side of their body. So therefore, the mannequin may not be able to depict that for you. So those are some challenges. Of course, physiological changes can happen. And again, sometimes it can be expensive, but like I said, you don't always need to have the highest end equipment. You can use simple improvisation to do what you have to do as long as your learning goals and objectives are clear. And sometimes funding can be a challenge. Today, there is still a divide in simulation-based learning, and one of these divides is actually the educational language divide. It is probably more prevalent in English-speaking societies, but of course, like in China, they have a big-time research into simulation-based learning with Mandarin, for example. In Turkey, I'm sure you have it in Turkish language, but there is still a big gap between English and the other languages. So therefore, if we can develop this further, it will be so much more, and if we can share across the board, across languages, that will be so much better as well. So I hope that I have been able to share with you snippets of how you can do simulation-based research, share it in terms of publication, and uplift the academic publications in your department, and also in the way you do it. If you have innovative ways of doing simulation, share with the world, because through publications, through academic work, you can actually get more sharing. So therefore, I hope that I have inspired some of you at least to start thinking. How do you get the ideas? It usually starts with a question. If you have something that causes you a lot of angst and anxiety, why do you have to do it this way? Can we change it? Can we do it in a different way? Well, simulation-based learning and research is the way to test it and to see whether you can have a better way and a better approach of doing this. And through research, you can then implement it into the clinical setting as well. And I leave you with a picture of the Singapore waterfront. This is our Marina Bay Sands waterfront area, which is one of the largest tourist attractions in Singapore. Thank you very much.
Thank you very much, Professor Fatima. It was your valuable contribution to simulations. Thank you very much. And I wonder, Dr. Fatima, can we train artificial intelligence with simulation methods? Yeah, I'm sorry.
Thank you. Yes. Yeah, certainly, Dr. Isa, AI is being integrated into our simulation-based research as well. A lot of it, for example, AI in triage, for example, we simulated a lot of this before we actually implemented it, and that is one of the commonest. And then, for example, we are using AI tools for geriatric patients who present to the emergency department, where often the psychological presentation is missed because we are always looking at the physical presentation. So we're looking at a screening tool that we can actually use using AI, and we're testing it out as well. So therefore, it's not just simulation-based, mannequin-based kind of work, but it's also technology-driven work, including AI. Thank you.
Thank you. Is there any questions from the audience or contributions about the simulations research? Okay.
Our next speaker is Dr. Lisa Moreno-Walton, who is serving as Professor of Emergency Medicine at the LSU School of Medicine. The title of her presentation is Ethical Considerations in Emergency Medicine. Welcome.
Well, thank you so much. It is an absolute pleasure for me to be here and to share some concerns about ethical considerations that are important in the practice of emergency medicine. I do have some disclosures. I'm a funded researcher, and I have textbooks that I do receive royalties from. And because I do a huge amount of my work in unconscious bias, diversity, equity, and inclusion, I will say that I am extremely biased in favor of the mission statement of AAM, the organization of which I was president, and also I am extremely biased in favor of diversity, equity, and inclusion and social justice. And my interest in social justice certainly has prompted my interest in ethical considerations. So when we look at the Hippocratic Oath, which is obviously the starting point for our practice of medicine, and it's very difficult for me to see that, and I wonder if I could have a mic that I could move so that I can see, but if not, until then, I'll try to speak as loud as I can. So obviously we have to work for the, thank you so much. And this is easier for me too because I'm short and I can see better this way. So obviously we must benefit our patients and do no harm and injustice to them. And this is where the concept of first do no harm comes from. We will not obviously give toxins to our patients. And I think it's important that in the Hippocratic Oath we also swear that we will keep our own life and our own practice of medicine using the word holy, meaning keeping it pure. And then in whatever house I enter, I will enter to help. I will abstain from any wrongdoing. And also, I will not essentially gossip about the patients that I see or the things that I learn about other people in the course of my life. And so the role of the physician is actually to be somebody who is a beacon of high-level ethics in the entire community. Now, that obviously was breached. It's been breached many times throughout the history of the world, but the most prominent time that it was breached and the time when actually action was taken was in the Second World War. And so the Nuremberg trials were actually set apart by 6 allied nations of the world in order to evaluate the murder of 6 million Jews and 3 to 6 million other individuals who fit in categories that the Nazi government did not think were fit to live. And so there actually was a trial of doctors, and this was rather appalling given the Hippocratic Oath, that doctors actually participated in extermination, doctors participated in torture, they participated in testing that was deemed research in order to learn different things about the capacity of the human body to endure cold, the capacity of the human body to endure starvation, the capacity, how long a person could live in boiling water, how many times a person could be shot before they died. Really terrible things were done. And so doctors participated in these things. And so the Nuremberg trials were regarded as a milestone for 2 things. First, to establish the fact that international courts have a right to adjudicate crimes against humanity. And second, the very fact that there is a precedent now for us to deal with instances of genocide and other crimes against humanity. And out of the Nuremberg trials arose the United Nations Genocide Convention, the Universal Declaration of Human Rights, and the Geneva Convention on the Laws and the Customs of War. And a precedent was set for further trials that took place, even going up as recently as our lifetimes. Now, the Geneva Convention, and actually there were 4 Geneva Conventions, and the most recent one was the one that took place after the end of World War II. And you will see that this defines the basic rights of wartime prisoners, civilians, and military personnel who have ceased to be engaged in combat. And it establishes protections for wounded, sick, and also for the protection of civilians who are in and around a war zone. And And if you read through the rights that are given in the Geneva Convention, you will see that most of these have been violated in almost every war that has ever taken place since the Geneva Convention was formed. The Geneva Convention forbids violence to life and person, murder of all kinds, mutilation, cruel treatment, torture, the taking of hostages, outrages upon dignity, in particular humiliating and degrading treatment, and the passing and carrying out of sentences and executions where essentially due process did not take place. And it says very clearly that the wounded and sick shall be collected and cared for. And if you look through this, you see that indeed this has been violated in almost every single war that has taken place since then. But yet we do hold those up. And how does some of this impact the way that we practice medicine today and the ethical considerations that we must put into the practice of medicine? So the Declaration of Helsinki was the first time that there was some action taken by physicians who particularly were engaged in research. And so the principles that came out of the Declaration of Helsinki, which is why we have IRBs and ethics committees in our hospitals today when we do research, were that physicians involved in medical research must protect life, health, dignity, integrity, the right to self-determination, privacy, and we'll come back to that again, and confidentiality of personal information, because that's also important in the kind of medical care that we render today. So what are our responsibilities as physicians? The first and foremost responsibility that we have is the duty to treat. And so the duty to treat is the physician's primary duty to make the care of the patient their first concern. So again, going to the Hippocratic Oath, we say that we put the patient's needs ahead of our own. So our ethics, actually, when you look at ethics, there's a concept in ethics that is called the general positive duty. And that means a duty or an ethical responsibility that every single human being has. That's why it's called general. And the most common example used is that if you see a toddler fall face down in a wading pool, everybody who's walking by has the responsibility to grab that kid's arm and pull them up out of the water so they don't drown. But special positive duty is an ethical principle that deals with our ability to do certain things that other people cannot do. So for example, a physician has to, it's something I signed up for, right? So a physician was obligated to treat COVID patients during the pandemic, just like during the plague years, right? Plague doctors took care of plague patients. During the influenza epidemic in 1918, doctors took care of influenza patients. We expose ourselves to infectious diseases. We expose ourselves to danger. The special positive duty concept in ethics, though, makes it very clear that you should be trained and properly equipped to take care of the patients in those situations. And an example that's often used when we talk about special positive duty is a fireman and a doctor are standing outside a burning building. The doctor stands and waits while the fireman goes in and gets the patients out, because a doctor doesn't have the specialized equipment or the specialized training to evacuate patients from a burning building. And so that whole concept comes up where we say, you know, a dead doctor can't save anyone, where EMTs are told, secure the scene first, because we have to take care of our needs in order to be able to take care of the needs of the patient. And that issue came up many times during COVID, when especially in the United States, people were not given adequate PPE. And the question came, well, if I'm supposed to take care of the patient, should not I also be protected from disease so that I can do my job properly? And that was a matter of ethical consideration. What is another ethical consideration that comes up? The ethical consideration when my personal ethics might conflict with a patient's needs. And so these issues come up commonly with termination of pregnancy, birth control, a lot of issues that have to do with OBGYN and other kinds of gender-related care, female circumcision, or what people sometimes refer to as surgical castration of women. These are things that where there's a lot of discussion ethically about whether this is something that a particular physician would do. So Yale School of Medicine actually looked at what the ethical considerations are as to when a patient care can be refused by a doctor. So even though I may have particular moral values that I might say I will employ for my life, I cannot force those moral values on other people. So I am allowed to say no to treat a patient if the patient is abusive, if the treatment is not in my scope of practice. So for example, if a patient comes in and asks me to resect a brain tumor, I can say, well, I'm sorry, I can't do that for you because I'm not a board-certified neurosurgeon. Or if the care violates my oath to first do no harm. So if a patient comes in and says they want me to do something that's actually going to harm them, then I can refuse to do that. But otherwise, I am obligated, all of us are obligated to treat a patient. Now, do you have to do that treatment yourself? If I am morally opposed to something that the patient is asking me for, but it is within my scope, it is a normal treatment, it won't harm the patient, then I do not actually have to do that, but I must facilitate that patient getting care from another physician or another medical professional. So for example, if somebody's religious, if a doctor's religion precludes them from prescribing birth control to an unmarried woman, they don't have to write the prescription themselves, but they need to facilitate the access of that woman to a physician who will be able to provide for their medical need. What about supporting patients' autonomy and addressing fears? So the three major classes of abuse are child abuse, elder abuse, and domestic violence. Every country has duty to report law to civil authorities. These are things that we have to discuss with patients. This is an ethical dilemma because it can often put you in a position where you are regarded as the enemy of the patient or the enemy of the patient's family. For example, if you suspect that a mother is abusing her child, in most countries, you have a duty to report this to the authorities, but now you have put yourself into a situation where the mother regards you as the enemy. And so these are situations that are very ethically tenuous, but it is important to report that to make the report you're obligated to make and to tell the family that this is my duty to report. It is not my duty to make a decision. So ethically, I do not have to adjudicate whether the abuse is taking place. Instead, if I suspect the abuse, I need to call somebody whose job it is to investigate that and make a decision. And that's what I tell families. My job is not to make the decision. I am still here to take care of the patient, but I have a moral and ethical responsibility and a legal responsibility to report the abuse. We also do have a responsibility to report an intent to commit a crime or an intent to harm another. So even psychiatrists who have an almost priestly confessional confidentiality with their patients, if a patient says, I am going to go and kill this other person, you do have a moral obligation and an ethical obligation to report that this person is in danger. And in the United States, if a person is being released from prison and they have harmed someone else, that person who was the victim needs to be told that the patient is being released from prison, and the same thing in a psychiatric hospital. If I have a patient who has harmed another human being and was put in a psychiatric hospital for that, I must then tell that person who was the victim that the patient is being released. So we have loyalty to the patient. We must observe what we call in the US HIPAA laws, which is the protection of health protected information, but we always must act in the best interest of the patient. So we want to have shared decision-making, but there are times when we can't. So in the case of a suicidal person, what is my ethical responsibility? If a suicidal person comes in, if a patient says, I want to die, don't do anything to help me, ethics tell us that we must assume that when the person is no longer suicidal, when their psychiatric needs have been addressed, they will no longer want to die. And so ethics tell us that even if at that point the patient is saying that they want to die, we are obligated to treat that patient even if it appears that we are doing it against their will. The other thing is the in loco parentis concept. So if I have a child that I'm taking care of, I must sometimes act in the best interest of that child. If the child is brought into the hospital and the parents are not available, I as the physician, act in the position of the parent. I do what is best for the child because that is ethically and legally the correct thing to do, even though I may not have permission from the parents at that point. And in certain circumstances, doctors also need to go against the wishes of the parents. So for example, if a child's parents say they cannot have a blood transfusion and the child will assuredly die without the blood transfusion, it's my responsibility to contact the family court and get an adjudication where I can act in favor of the child, because I do not know when the child turns 18 or reaches the age of reason that the child is going to choose that particular religious belief. The concept of assent is important. If the child is of age, we do ask them. They cannot give consent, but they can give assent and say that they agree with the treatment. What about when we have to testify in court? So ahead of the court case, our job is not a fact-finding mission. We are there to treat the patient and take care of the patient and not to gather information for anybody else. But when a medical case might become a court case, then I need to tell the patient or the family that this situation may take place. So if there has been some illegal activity, for example, if a person has been driving drunk, sometimes the police will come to the hospital because they were at the scene of the crime and they will issue a ticket. So sometimes the medical case becomes a court case, and what is the difference between my obligation to quote unquote the people or the crown and my obligation to the patient? So my obligation is first to stabilize the patient, to first take care of the patient, to first make sure that the patient's life and limb are protected before I provide any other information, and then to provide information only in the legal context, because my obligation is to first do no harm. So we are expected to be role models and citizens in the community, and we must obey the law. I remember when I did my psychiatric rotation as a medical student, the psychiatrist said, our responsibility is to obey the law or to seek to change it. But what if the law conflicts with our oath? So we do need to think about that. And the greatest example of that were the Dutch physicians in World War II, where the Dutch physicians refused to perform euthanasia, where they refused to work in the concentration camps, and many of them even sent their medical licenses, mailed them into the Nazi Party and said, we do not work for you. We've taken a sacred oath to protect our patients, and we will not exterminate any patients. So we must also remember that when we are practicing in a war zone, which some of us do, and that has become an important issue recently for many physicians, this is not political, or at least it should not be. I am a doctor. It is my responsibility to treat all patients. I don't want to know which side a person is on. I don't want to know what a person might have done or not done. My job is to keep that patient alive. And I always say that blessedly, I'm not a judge, jury, police, or God. My only sacred duty is to heal and to keep my patients alive. So in conclusion, what have we learned? Our oath demands that we keep ourselves holy and free from malicious harm or gossip to our patients. The Nuremberg trials established international courts and a precedence of the prosecution, including of doctors who commit crimes against humanity. The Geneva Convention protects non-combatants, both healthcare workers and our patients. We have a duty to treat. We signed up for it. We cannot refuse care except in cases of abuse, scope, or oath. Otherwise, we have to either provide the care or arrange the care. You should know your mandatory reporting laws for suspected child abuse, elder abuse, or domestic violence. You must follow those laws, and you have to inform patients that it is your obligation to do so. Always act in the best interest of the patient, including in loco parentis status when dealing with children or someone who is impaired by alcohol or mental illness. Do not act as an agent of the court in the absence of a subpoena. And always, ethically, always do the right thing. We also have to remember when some of us go to work in war zones that war is not political to the physician. We don't take sides, although we may in our personal lives and we may have opinions about things, but when we're taking care of a patient, our job is to save lives. I know I've raised a lot of controversial issues in a very short period of time, so I hope I've given you some clarity and a lot of things to think about. Thank you.
Thank you, Dr. Lisa. We are now open for questions.
Should I give this back to you? Or to you? Thank you.
Okay. Thank you very much.
Thank you very much, Professor Lisa Moreno. And I would like to thank to all distinguished speakers for once again for their informative presentations. And we have gotten on over the time. The last speaker.
The last speaker was supposed to be an online speaker, but for various reasons, we will not be able to offer that presentation. So this session is now concluded. So thank you very much for your participation and attendance.
in this area can quickly lead to the hypoxia, to the brain death, or even to the brain damage, or even to the death. We start, of course, at the beginning with the manual maneuvers, but if you want to secure the airway management, we escalate to the advanced, such as intubation or surgical access. Knowing those techniques well, practically and theoretically, is life-threatening, literally. So, at the beginning, children's airways are not just smaller, they are fundamentally different than in adults. They have proportionally larger tongues, which can easily block the airways. Their epiglottics are omega-shaped and floppy, making it harder to visualize the vocal cords. The larynx is more anterior, around C6, C7, which changes our approach to the intubation. And importantly, the trachea is much shorter, increasing the risk of the accidentally intubating the main bronchus. Those features demand careful planning and precise execution during the airway management in pediatric patients. Adults, on the other hand, have smaller tongues and firmer, more easily visualized epiglottics. The larynx is positioned more posteriorly around C4, C5, and the trachea is longer, which gives us a wider safety margin during the endotracheal tube placement. Those failures generally make airway management more simple in the adults. However, certain pathologies like trauma, like obesity, like tumors, in emergency medicine, the restricted mouth opening or the restricted place in which we can perform the endotracheal intubation can significantly alter adults' anatomy and turn a standard airway into the difficult one. When we're talking about the airway management, we can divide those devices and divide those techniques in several types. Firstly, is supraglottic airway devices. Since 2017, because before then, the gold standard for the cardiopulmonary resuscitation for the airway management in CPR was the direct laryngoscopy. But since 2017, when the guidelines of the European Resuscitation Council and the American Heart Association changed our thinking, the supraglottic airway devices are equal to the endotracheal intubation during the CPR. So the supraglottic airway devices are commonly right now used in the emergency medicine and in the short anesthesia. It's relatively easy to insert, to obtain the airway management. In Poland, for example, each firefighter are trained to use the supraglottic airway devices in the emergency situation when the EMS is not on the place. Those devices, as you see on this screen, we have many types of those. We have supraglottic LMA, I mean the mask airway, we have tubes, we have iGel mask, we have combi tube, easy tube. There are really huge number of potential devices we can use. Of course, those devices has also some limitation, and for example, we shouldn't use those devices in patients in which we suppose the risk of aspiration. The second type is endotracheal intubation, and also we can divide those into three groups. I mean, the first one is direct laryngoscopy. We use the direct laryngoscopy mostly during our shifts. It's gold standard still for airway management. Involves applying oral, pharyngeal, and laryngeal air access. Requires skills and the word skills is important, because to obtain the skills which will be able to perform endotracheal intubation, we need to perform near 20 intubation per year. And during the first training process, we should perform about 70 intubations. With the direct laryngoscope, I mean the laryngoscope with the Miller or Macintosh blade. The second group is videolaryngoscopes. Of course, those devices has the higher first access success rate comparing to the other methods. However, they are potentially costed. We suppose the fogging of the camera. However, the new types of those devices has special surface anti-fogging, so it's relatively easy. We have also many different laryngoscopes. However, the learning curve when we're thinking about the videolaryngoscopy is relatively shorter, because we need to perform 4 to 5 endotracheal intubation with those devices to have the potential skills to perform it in the future. However, when we train the new generation of emergency medicine, we should focus at the beginning of the direct laryngoscope and treat the videolaryngoscope as something added to the training, because videolaryngoscopes are new devices, of course, but it requires porous surface. Many things don't work in videolaryngoscopes, so we should know in the old school how to perform endotracheal intubation. And the last in this group is fiber optic intubation, which flexible scope with the lighted tip used to guide endotracheal tube into trachea. Sometimes all non-invasive methods failed, and if we need to perform ventilation of the patients and we have the situation which cannot ventilate, cannot oxygenate, we need to establish a surgical airway. So for those, we have those two techniques. As I said previously, the videolaryngoscopes have the higher first pass success rate, especially in the difficult airway. We see the better glottis view and improve safety margin, and establish supervision and teaching using the videolaryngoscopes. And I want to show you several, from my perspective, important studies which show us the benefits of the videolaryngoscopy over the direct laryngoscopy. And for example, right now you see the first access success rate, first intubation success rate in different videolaryngoscopes comparing to the direct laryngoscope. This graph is from the network meta-analysis of the randomized controlled trials, and we see interesting things, that no matter in which situation we have the patients, is it cervical immobilization, obese patients, or intubation in the emergency department, videolaryngoscopes are better than direct laryngoscope. And we have many different videolaryngoscopes. We have channel videolaryngoscope, like King Vision. We have Macintosh blade videolaryngoscopes, high angle videolaryngoscopes, videostillets. All of those devices are better than direct laryngoscopy. When we're thinking about the pediatric intubation, we have another meta-analysis, and as you see on this screen, the first pass success rate when we comparing videolaryngoscopes to the direct laryngoscopy was 75.9 to the 72.9%. And this data was significantly, and P was at the level 0.001. When we Talking about the adverse events, because this is also important from our perspective, the number of adverse events were higher in the direct laryngoscopy and obtained in this situation 33.7% comparing to the 28.8 when we're talking about the video laryngoscopy. However, those differences were not significantly. When we thinking about pediatric patients, of course we have we have infants, we have older childs. So you have see on this screen another meta-analysis in which they divide the time to intubation needed with the video laryngoscopes and with the direct laryngoscopy into those two groups, I mean child and infants. And in both groups, the intubation with the video laryngoscopy was faster than with the direct laryngoscopy. On this screen, you see the first pass success rate. And we see that in the infants, the difference between video laryngoscopy and direct laryngoscopy was not significantly statistic, but in the children, it was statistically significant. So we should use those devices mostly in the over the 1 year of the patient. Of course, as I say previously, video laryngoscopy also help us to visualize the glottis, and we see the confirmation, for example, in the Cormack-Lorraine score and the POGO score, and in both situations, the glottis visualization was better with the video laryngoscopy. Another slide shows us the adverse events of the both two endotracheal intubation techniques, and we see that the endotracheal intubation with the video laryngoscopes perform much more lower rate of trauma comparing to the direct laryngoscope, perform the lower rate of the desaturation comparing to the direct laryngoscopy. However, perform the much more higher rate of the hoarseness comparing to the direct laryngoscopy. But from our perspective, the trauma, I suppose, and the desaturation are much more important than hoarseness. And at the finish, the video laryngoscopy is already changing our practice, and its use continues to expand. 3D printing technology established the creation of the patient-specific airway devices and a promising frontier for those with the unique anatomy. Those advantages are shaping a safer, more personalized future for the airway management. And summarizing the effective airway management is both a science and the art, and we should remember on it. It requires deep anatomical knowledge, technical skills, and the ability to respond rapidly for changing situations. Thank you so much.
Thank you. We have time for 1 or 2 questions. Does anybody have a question that they'd like to give right now? Oh, do we have a microphone up front?
Thank you very much, Professor Lucas. You share the difference between using direct laryngoscopy and also video laryngoscopy. That's okay. The topics was about the management of the airway. So especially I'm wondering about while you are managing the airway, could you want to talk about the procedure anesthesia for the child? So this is really very important for management of the airway of adult patients, pediatric patients.
So, at the beginning, we should know that the procedure of the airway management, I mean the endotracheal intubation and preparing to the endotracheal intubation is totally different in the emergency medicine situation and the anesthesiology, because in anesthesiology we have, of course, time to pre-oxygenate patients, to check the airways, we have the assist, but in the emergency medicine we have much more less time, so we need to work rapidly. And in the pediatric patients, in our perspective and our work, if we suppose that patient has some abnormalities of the airway and we can predict the difficult airway, at the beginning we start with the video laryngoscopes. Other way, we start traditionally with the direct laryngoscope and we try to perform it in maximum 2 attempts, and after then we perform, if those attempts were failed, we perform the video laryngoscopy. Besides, in each resuscitation table in our hospitals, we have both devices, I mean the direct laryngoscope and some kind of video laryngoscope. And if it doesn't help, we have also some kind of supraglottic airway devices. Mostly it's iGel mask because it's relatively easy and fast comparing to other devices.
Thank you very much, Dr. Sarpak. Okay. We can pass the next section. As we know that we faced a severe pandemic, COVID, in a short time ago. Now our topic is epidemiological lessons from COVID. The speaker is Dr. Chikitsa Amin from India. Sorry for my pronunciation. She is interested in infectious diseases, maternal and child health, and also epidemiology. Thank you, Dr. Chikitsa.
Good evening all. First of all, I am very much thankful to the organizing team, EPAT, especially Dr. Bassar and Dr. Sagar, for giving me an opportunity to deliver a speech on this platform. So, epidemiological lessons from COVID-19. So, outline of my presentation, introduction, impact of pandemic and challenges, responses against pandemic, that is on global base, India and local at institution level, lessons for the future implication. The coronavirus disease, that is COVID-19 pandemic, is a global outbreak of an infectious disease caused by the severe acute respiratory syndrome, coronavirus 2. Cases of novel coronavirus were first detected in China in December 2019, with the virus spreading rapidly to other countries across the world. WHO announced public health emergency of international concern on 30th January 2020 and subsequently declared as pandemic on 11th March 2020. What are the impacts of pandemic of COVID-19 on health, on healthcare system, on environment, lifestyle, and socio-economic? If we see the effects on health, it's basically direct impact and indirect impact. Indirect impact, the healthcare infrastructure was overburdened and the medicines, they are diverted for the COVID-19 treatments. So it will lead to infectious disease outbreaks like malaria, tuberculosis, and HIV/AIDS. In indirect impact, there was failure to seek urgent emergency care and increased need for mental health and substance abuse services, which will lead to the acute illnesses like heart attacks. Episodes of heart attacks were increased. If we see the intermediate impact, the supply chain of non-COVID-19 medicines, it was disrupted and disease treatment was deferred, which will again lead to some preventive outbreaks like measles, mumps, and rubella as the routine vaccination activity was hampered. So overall, there was decrease in the primary care physician visits due to redeployment of staffing for COVID-19. Now the impact on healthcare system, as we see in previous slide, the impact on health, that is infections were increasing, deaths were increasing, increase in stress and other mental disorders. On the availability and distribution, there were shortage in the health staff and vacancies. The surge capacity was increased and SARS-CoV-2 related absence was there. If we see the working conditions, there was lack of personal protective equipments, labor strikes were there, quarantine and self-isolation, temporary staff contracts, lack of incentives and insurance, the violence and harassment was increased, lack of psychological support and lack of COVID-19 vaccination. If we see on social and well-being, there is stigmatization and definitely the discrimination. The care for the family members was hampered. Now the impact on environment, there is positive as well as the negative effect on environment. If we see the positive effect, as the consequences of worldwide lockdown, the air quality was improved. Then there is decrease in the emission of the greenhouse gases. If we see the negative impacts, the consequences of management of COVID-19 positive patients, due to that, the production of biomedical waste was increased. There was contamination of water and soil by the patient excreta and antimicrobial chemicals in water system. The impact on lifestyle, definitely the physical activity was decreased, the screen time was increased, which will lead to mental and sleep disturbances. There was also a problem related to the unbalanced diet. So all this we can prevent and therapeutical strategy was there. So related to the physical activity, at least 60 minutes per day of vigorous or intense physical activity 3 times per week. Screen time, it should be reduced because of the online teaching and studying, it was very much increased. And after COVID-19, the addiction of this mobile addiction was very much increased. So we should engage the people in the gymnastics with some music, some hobby, run on the spot, dancing, playing with the brothers and sisters or with the parents and carrying out the housework. For mental and sleep disturbances, the psychotherapeutic and pharmaceutical approach was there. For unbalanced diet, we should promote healthy diet and evaluate micronutrient supplementation. If we see the impact on economy, this figure shows quarterly worldwide GDP and GDP forecast in January 2020 versus January 2021 and 2019. There was a deep fall in the GDP. If we see the overall impact of COVID-19, the summary and challenges. So, challenges to the healthcare system during COVID-19 pandemic, the prevalence of non-communicable diseases like diabetes, hypertension were increasing because of the disturbed lifestyle and increase in the stress, there is also burden of infectious diseases. There was fail to address maternal mortality rate and infant mortality rate as the routine antenatal visits were hampered because of the stigmatization and people were very much scared, so they didn't went for the routine antenatal checkups. Same way, the routine vaccination activity were hampered, and they lead to increase in the maternal mortality as well as in the infant mortality. There was lack of infrastructure as the caseload was very much high. The doctor and patient ratio was low. The less expenditure on GDP, and there was definitely shortage of skilled manpower. All this is because of the unmanageable patient load. Now the responses against pandemic. WHO COVID-19 Strategic Preparedness and Response Plan, that is continued delivery of a coordinated and comprehensive health response at the national levels. United Nations humanitarian response with coordinated and integrated COVID-19 response, in which essential supplies, that is, they delivered the lab testing equipments as well as and medical supplies. In the infrastructure, the hand washing stations were developed as the campsite as well as at the settlements. In the public information, they launched a public awareness campaign to aware the patient, to educate the public regarding how to prevent themselves as well as their family members from the COVID-19. In the logistics, they've established the air bridges and hubs across the Africa, America, and Latin America and Asia to move the humanitarian workforce and supplies. Vaccine development and distribution, then testing and contact tracing, transformative and sustainable recovery, the framework for immediate socio-economic response to COVID-19 to address the socio-economic impacts. This figure shows 3 years of pandemic learning response. In the year 2020, they launched the first COVID-19 course 4 days before emergency declaration. There were increased open WHO enrollments from 0.16 to 4.7 million. They produced 22 COVID-19 courses across 43 languages and translated 6 million words for COVID-19 learning. In 2021, the expanded platform reached to 6 million enrollments, increased participation of underserved demographics. They added 18 COVID-19 courses and 14 languages, launched country-specific channels for WHO country offices to publish learning in their language. In 2022, they responded to 40 disease outbreaks in addition to the COVID-19 pandemic, increased platform participation to 7.4 million enrollments, provided courses on 190 health topics with 46 for COVID-19 across 65 languages, and hosted 15 country channels for WHO offices. Now in India, December 31, 2019, first COVID-19 case was reported in China, and then in 30 January 2020, India's first COVID-19 case was reported in Kerala. In March 19, 2020, first COVID-19 case was reported in Gujarat. On 23rd March 2020, the suspension of services of Indian Railways and all the flights operations. On 25th March 2020, nationwide lockdown phase 1 was declared from 25th March to 14th April. On 14th April 2020, nationwide lockdown in green, orange and red zones, that is the phase 2 lockdown from 14th April to 3rd May. On 25th April, a restriction that is lifted from small retail shops, COVID open with the 50% of staff. On 17th April, Vapi and Ankleshwar under the red zone due to the rising of COVID-19 cases. There were different zones, that is color coding wise, red, yellow and green zone. On 29th April 2020, interstate transportation allowed for stranded persons only. On the 3rd May 2020, Vapi and Ankleshwar, they moved to orange zone. On the 4th May, nationwide lockdown phase 3, that is from 4th May to 17th May was declared. And on the 19th May, the nationwide lockdown, that is phase 4, from 18th May to 31st May. Relaxation was allowed except in red zone without further divided into containment zone and buffer zone. The containment zone, the zone in which the concentration of COVID-19 cases was very much high, and the buffer zone that is surrounded by this containment zone. So the buffer zone in which movements was not restricted stringently, but in containment zone, the movement was restricted to prevent the spread of COVID-19 cases. And on the 1st June 2020, unlock phase started, that is unlock phase 1 from 1st June to 30th June. India rolls out the worldwide largest COVID-19 vaccination drive, in which the vaccination coverage as of on 17 January 2020, 157.20 crore India's cumulative COVID-19 vaccination dose. India developed a digital platform that was known as the CoWIN app, which was delivered to manage the vaccination drive, in which the patient, they can register themselves for the vaccination schedule by the online applications. The patient were able to download their COVID-19 vaccination certificate from the online or from their mobile application, and that certificate was used for the transportation. It's a proof of vaccination. The another app that is known as the Arogya Setu, it was basically for the tracking of the patients, and as the Arogya name suggests, Arogya means health and Setu means bridge. So it was a bridging between the community and the healthcare facilities. So the patient, they can do the self-assessment, they can know the case load of their area and the nearby patients. They can track, the COVID-19 patients were tracked by using the Bluetooth as well as the GPS tracker were there. The number of laboratories were increased from 2020 to 2021. So it was 2,504. Now the responses against pandemic at our institution level, the rapid response team, in which the contact tracing, home visits of COVID positive patients, evaluation of community survey by the field workers, vaccination drive using CoWIN app, data management and death audit, and community awareness session. In rapid response team, were doing the contact tracing. Where the case was notified, we visited that area, that patient, and their family members, they can be traced and they can be checked by the temperature gun as well as the SpO2, that is with the help of pulse oximeter, the SpO2 was measured in the community. And that in that way, the contact tracing was done. Then the home visits of COVID positive patients, the patients were home isolated and or we can say the home quarantine. Then the evaluation of community survey done by the field workers. Data management and death audit was done at our institution with the help of our department, that is community medicine. The community awareness session were conducted with the social worker and the public was aware regarding COVID-19 awareness and how to prepare themselves as well as their family members. So the use of mask, the importance of hand washing was that type of sessions, awareness sessions were conducted. Now the lessons need to be learned. We need to learn lessons from the COVID-19 pandemic for better preparation against future infectious disease pandemics by strengthening global health system, improving public health infrastructure, enhancing capacity for rapid response, effective communication, addressing social and economic disparities, and promoting international cooperation. Strengthening global health system by teleconsultation and by increasing the healthcare workforce. Improving the public health infrastructure by means of 3M, that is manpower, money, and materials. Enhancing the capacity of rapid response by public health emergency preparedness with the help of, that is RRT, then personal protective equipments and vaccines. In the effective communication, resilience and community involvement. So community awareness sessions should be conducted regarding this type of epidemics. Addressing social and economic disparities, disparities in the inequality by targeted interventions, and addressing mental health is also very much important. Then promoting international cooperation by sharing data and best practices and by the good governance. Thank you all for quiet listening. So I would like to say that prevention is better than cure for any disease. Thank you.
Thank you so much, Dr. Chikitsa. And lessons need to be learned. Section was so clear and so nice, and you finished just on time. Thank you so much for your great presentation. Is there any question? We have a quiet time. So, okay, turn is yours.
Our next speaker is Dr. Sanjeev Boy. He's a full professor at the All India Institute and the director of the WHO Collaborating Center for Emergency and Trauma and the director of the International Network of Critical Ultrasound. And he's going to speak to us on block on arrival in the emergency department.
Thank you, chairpersons, for giving the opportunity to speak about the concept which we implemented a few years ago. With a concept, because one of the benchmark of any emergency medicine department is providing a quality pain assessment and pain therapy service, one of the benchmark. But it is the least addressed in any emergency department, globally. So there is an element of oligoanalgesia. So as an initiative, or various initiatives we took, is to create a concept called as pain-free emergency department. That is a tagline. And so it was a patient-centric approach we took. And the concept was block on arrival. As one of the multi-model approach to a pain-free emergency department. So we discussed this topic with the objective of this topic is going to address what is the burden of acute pain in emergency department. What is this concept of block on arrival? I'm going to discuss two of the very important research work which we conducted about the PENG block and the FICB in acute hip fracture, hip and shaft of femur, and addressing acute pancreatic pain, which is itself is a topic with a new topic, and some of the newer blocks. So you can understand what his initial statement was, is the most frequently encountered complaint in the emergency department with often oligoanalgesia. As I said, multimodal approach. And one of the key approach we took is to create a concept of ultrasound-guided blocks and various other blocks in the emergency department. So this is a journey over last 12 years of work in the emergency department. It has been the anesthesia domain over the years. There's a lot of inertia when we started off, the concept of pain-free ED. So they were saying, how come you guys are doing it? So what we did is, we are addressing acute pain service. We wanted to provide acute pain service for procedures and pain relief. And that's why I also wanted to, have an opiate sparing, initiative. Anyway, opiate is not very, it's a lot we don't give it in India, but we wanted to actually, avoiding that. If you see the American College of Emergency Physician guidelines, emergency physicians, it was in research that it is competent to do ultrasound blocks in the ED. So it all started in, as I said, 2010, 11, there was one paper from Michael Stone. And that time, one was a resident from Queens, New York, was rotating under me, Amit Chandra. I remember that first case series of 8 blocks in the emergency department I gave, after training. We started with actually a brachial plexus block, interscalene brachial plexus block. And after initial case series of 8, we published another series of 50 in both upper limb and lower limb blocks in the emergency department for pain and procedure. And that gave a sense of confidence in the emergency department. I started training my residents. That time, we didn't have MD emergency medicine. We had residents from medicine, surgery, orthopedics who were rotating under me in the emergency department. But I led by example. I did it myself, trained the residents, and make them feel, especially the orthopedic residents, he believed that, yes, this can be a big solution for our patients who keeps on wailing in the emergency department, crying in the emergency department due to pain. And most of us, we only give what is called a vocal anesthesia. Oh, nothing will happen, just keep it down. And what I did is trading off. Like, I wanted to learn the orthopedic procedures, like reductions, from my orthopedic resident, and he wanted to learn blocks from me. That was the trade-off we created. So over the years, then it sank in the emergency department. Last 3 years, we took a concerted approach. I'll talk about that. This is a paper we published over the journey of this thing. So if you see that we use both upper limb blocks, thorax, and the lower limb. For pain, we actually used for pain and reductions, both for debridement, we use the blocks in lot. But for addressing pain was the topmost. So I'll talk about 2 important blocks, which we did as a randomized control trial. It was the one on the pancreatic, we're going to speak a bit later, but let me talk about one of the commonest problem in the emergency department is hip fractures. Hip and femur fracture is quite common in the emergency department. So we used, and initial years, I was giving femoral nerve block when the blocks such as fascia iliaca and PENG had not come. So I was, trained. So over the years, much safer blocks came that is called as plain blocks, volume blocks and plain blocks. So fascia iliaca was the next block which became quite popular in hip fractures and femur fractures. Then came the PENG. After giving initial, it was amazing pain relief of the patients. In case series, we did that. Then after we had experience of femoral nerve, fascia iliaca, and PENG, then we planned this propensity score match cohort study. So this was I was talking about, all the three blocks. So PENG is nothing but it is actually a combination of obturator nerve, accessory obturator nerve, and femoral nerve. So it is called as a PENG, means pericapsular group of nerves. Okay? So it supplies both hip joint, including the superior and inferior pubic rami. This is one block which for pelvic fractures also it is cool. Because no other blocks gives you analgesia in the pelvic fracture like superior and inferior pubic rami. So this is the two blocks I was talking about, is PENG is very safe block when compared to FICB or fascia iliaca compartment block. If you see that the fascia iliaca compartment, you need to, though it is superficial, then the nerves and vessels are nearby. But in pericapsular group of nerve blocks, there is no nerves and vessels in the pathway of the needle. So you go straight away and hit the bone and give the drug. This is, I was just talking about the supplies. So the objective of this paper was to investigate the efficacy of PENG versus FICB in traumatic hip and femur fracture in terms of pain control in the ED. And secondary objective was to compare opiate uses in both the arms and to compare the adverse events in both the arms. So it is a prospective, non-randomized study, single center, ED based over a period of actually 1 year. If you see the criteria, inclusion criteria was adult patient of 18 years or more, traumatic hip and proximal femur fracture, and eligible for the block. So contraindication were those who had contraindication to any nerve blocks, we excluded that, and consent, if they were not giving, so we excluded them. So the methods were in the treatment arm, you can see treatment allocation arm on the discretion of the treating team, and the treating team was emergency physicians trained in blocks. So the endpoint assessment was pain control using visual analog score. Patient assessment was done just prior at the baseline at 30 minutes and 60 minutes after giving the block. And any patient, and the patient was observed for 12 hours in the emergency department. Rescue opioid use after the block was given if the patient's pain score was more than 7. Adverse event, we are trying to see that whether the patient had any block site infection in the follow-ups, vascular injury, any evidence of local anesthetic induced systemic toxicity, that is last, or any side effect due to opiate use in the arm. If you see the number of patients receiving peripheral nerve blocks in the ED was 333 overall. However, those patients who were not fitting in this group were excluded, such as 184 were excluded due to other types of peripheral nerve blocks which we gave, such as erectus spinae, 76, hematoma blocks, we gave a lot, serratus, they were not included in the study. So, coming down to 148 patients, they were eligible. The number of patients included in the patient after initial unmatched analysis was 104, because there were missing information in 34. And both of these patients group were divided into FICB 52 and PENG 52. And then propensity score matching was done. Out of that, we had 24 and 24 after we matched. So the comparative pain score was, there was baseline almost 8 to 10 was the pain score with the interquartal range, median interquartal range of 9, and there was significant pain reduction at 30 minutes and almost 50%, and at 60 minutes there was almost 75% of pain reduction with the interquartal range. However, the results of secondary endpoint was total morphine, which in milligrams equivalent to within 12 hours post-block was 12 milligrams in PENG, and FICB was 14. So there was nothing much to choose between the two. And none of them they reverted any any side effects. The previous study by Liang et al. In 2023 also echoed the same FICV versus PENG. They did not find any difference in any adverse events. But though there was similar pain control in PENG is similar to FICV in hip and fractures in terms of pain control, rescue, operative and adverse event. There is nothing to choose between the two. But considering the physician's preference on the floor, when I did and my residents are doing, we're very comfortable with PENG block, you can go straight away and hit there because there is no vessel in the pathway when compared to FICV. So because hip fracture was the most commonest thing we were using, so we did this thing. The second one, very interesting, was a new thing which we did is acute pancreatitis pain. Pain due to acute pancreatitis and acute on chronic pancreatitis is severe. The patient keeps on tossing on the bed with severe pain. And most of the emergency department, they give morphine or fentanyl. And patient actually develops grogginess. The quality of life in such patients are really pretty bad. And we have seen patients crying there. So what we did is, I tried first, I did a case series first using of erector spinae block at the T7 level. At the T7 level where the actually pancreas, dermatome of pancreas is there. Gallbladder, pancreas, T7 level. Both sides I gave 15 ml, 15 ml LA with dexamethasone 4 milligram. Amazing response. The pain score from 10, it became almost 2 or 1 after 30 minutes. And patient, we had to stop they no need to continue the fentanyl infusion for the patient. And patient recovered early, started taking orally early. So this case series of 8 patients, I shared this with our gastroenterologist. Because what they do, gastroenterologists they do, is for severe pancreatitis pain, they use celiac plexus block, which they do, what did they do? They do capsule endoscopy, and then they do invasive celiac plexus block, which is near the celiac vessels, which is dangerous. And when he heard this, I showed him some 8 cases before we published that. He was really very happy. And we published that as the case series of 8. And after that, we planned a randomized control trial. So this erector spinae block versus conventional pharmacotherapy in elevating pancreatitis pain in the ED. So this was the thing we did. So we know that opiates have its own side effects, okay? And erector spinae block, which I talked about, is really, gave a lot of hope, and that's why we planned this block. The mechanism of action is, it targets the interfacial planes between the erector spinae muscle and transverse process of vertebrae. The LA spreads to the paravertebral and epidural space, blocking both dorsal and the ventral rami of spinal nerves. That is maybe the plausible hypothesis, because not much work has been done. This is how we do erector spinae block. The patient is making them lie down prone, and let me tell you, this pancreatitis pain, they'll feel happy if they lie prone, because the pain automatically reduces. They cooperate with the patient, and you give LA 15 ml on the right side, 15 ml on the left side, because of both sides of the paravertebral space. And you hit the transverse process of T7. So what we did is, with the objective, the primary objective was to assess the efficacy of successful analgesia, defined as rifansine veteran pain scale less than or 3, after 6 hours of intervention, both in the block arm and the conventional pharmacotherapy arm. And the other objective was to see the drug and procedural related safety issues in both arms. The secondary objectives were pain score assessment at different time points up to 24 hours, total fentanyl consumption via PCA pump in both arms over 24 hours, total and successful attempts of PCA pumps in both arms, the duration of successful analgesia, total time taken for block, and how the patient felt about the satisfaction scores among the patient who received block or the therapy. The study design again is a parallel phase 2 randomized controlled trial at AIIMS Emergency Department over 18 months, and 18 years and above presenting with pain score more than 7. And sample size we took a 60-30 in each arm. So those patients, they were randomized into 1:1 basis using random sequence generated by web and through a snooze technique. One arm they received tramadol, injection 50 milligram TDS 3 times a day and connected to PCA pump with a fentanyl infusion of 10 mics per ml with 1 ml per hour and continuous infusion, and with a demand dose of 15 mics and a lock period of 10 minutes and 4 doses allowed in 1 hour. And the other arm, the same thing but with a rectospinal block. And rescue fentanyl is given whenever it was required. This was a consort flow chart. It was intention to treat analysis was done on 60 patients. Those who were initially entered were also analyzed. The results were very interesting. If you see the conventional pharmacotherapy arm, the patient, both they're equally matched. The pain score was 8 and 9 in other thing. And what you can see, the pain score over a period of time in both arms. You can see the significant decrease in the pain score in the erector spinae block arm when compared to the morphine, the opiate arm at different time points. You'll see the PCA pump matrix is total attempts of PCA pump was more in the drug arm when compared to the block arm, significant. Hence, you see that the total fentanyl consumption was more in the drug therapy arm when compared to the erector spinae block arm, almost quite less, and there's a significant finding. And duration of successful analgesia, almost 21 hours, patient was pain-free, in the block arm when compared to the drug arm where it was only 9 hours, significant, statistically significant. Procedure time, within 10 minutes, all the procedures were done. This is very interesting, patient feedback. So we took in the block arm, you can see almost out of 30 patients, 29 patients were satisfied or well. Out of the satisfied group and above. When compared to the drug arm, only 11 patients were satisfied. No, there are no side effects, significant adverse events either in the erector spinae block arm or the drug arm were noted in all these patients. Though it was a limitation was single center study, relative small sample size, open label design, all blocks were performed by a single performer. So only clinically stable patients were recruited in this case. So this was the first, actually, one of the very limited literature in this era. This is one of these things under review for publication right now. This opens up a new therapy for pancreatitis pain-related patients. So its clinical implications are huge. Broader impact of pain management practices can be done. Future research is required as a multicentric study. And this is another thing. And some of the newer blocks one can explore is, again, studies going on stellate ganglion block on refractory ventricular arrhythmia. The study is under process right now. And a new thing is you can also explore newer avenues such as erector spinae block in acute lumbar backache, severe lumbar backache. After you rule out red flags such as AAA or cauda syndrome, you can give this drug. So this is what was redefining pain management in emergency department, that is block on arrival and create a pain-free ED in the residency program. Thank you very much for listening to me.
That was a fantastic lecture, I just want to say. We only have, we're actually negative time here for questions. So I'm sure there's probably going to be some questions here. So if you can stick around for 20 minutes, would you mind?
Sure.
And then we'll get to our last speaker.
First, can I ask a question? Is there any question? Yes, just one more. Dr. Bonjevi, relieving pain is an art, and your presentation was also so valuable. Your studies were so valuable. But I missed something, or I couldn't see. Thoracic pain tends to last longer, thoracic pain. So which drugs, which agents did you use for thoracic pain?
Thoracic pain?
Yes. For example, reduction pain, is it useful? Oh, yes.
Yeah. So good question that how much, which agents I used for thoracic pain. See, first of all, in thoracic pain, I did not discuss in this thing, but we give serratus anterior block or erectus spinae also if they are posterior fractures. And the agents we used was actually a combination, it was the bupivacaine we gave, 0.25%, because that was the only thing we were available in our emergency department. So that combination of lignocaine plus bupivacaine can be given also. Plus I added 8 milligrams of dexamethasone.
Excellent.
Yeah, if you use dexamethasone, it slightly longer the duration.
Yes.
Newer drugs are available, but it is not with us, like ropivacaine and all that.
Thank you so much. Now, the last speaker, he is a surgeon, cardiothoracic surgeon from Malaysia, Professor Dr. Raja Amin.
First and foremost, I would like to thank the faculty for allowing me to speak at this wonderful meeting. I am, as you said earlier, I am a cardiothoracic surgeon. Unlike in Turkey, where you divide the cardiac and thoracic separately, in Malaysia, we are both, actually 3 specialty, cardiovascular and thoracic surgery. So we handle all 3 areas. So before I start, I would like to just show you that I come from this hospital in Malaysia. It's a new hospital and another hospital too. So it is a newly built hospital. Recently, about 5 years ago, it was officiated by our king, and it's a wonderful facility. So to start off, I think today we're going to talk about cardiac trauma, which I think is a very important topic, maybe because once you diagnose it at the emergency level, it's like a countdown. Things have to move rapidly in terms of making a diagnosis and also treatment. Okay, the most common causes would be penetrating and blunt chest injury. Okay, so you need to have a rapid diagnosis, and early surgical intervention is very critical. So one has to have a very high index of suspicion. So if you look at some of the pictures, just to guide you, I show you 2 chest x-rays. One has the above one, let me see, try this. One has a right pleural effusion, which is probably a hemothorax. And the next one is an upper mediastinal widening, which probably indicate an aortic injury. And of course, the other 2 pictures I put up, one is a typical cardiac contusion, may not present very openly to you, but if you do surgery, you can see the bruises on the heart itself. And of course, the last one is a stab wound as a representative of the penetrating type of injury. I'll go a bit detailed further. Okay, the type of cardiac trauma, of course, I mentioned earlier, penetrating injury usually is a gunshot wound or a stab wound. And blunt trauma, usually you find in MVAs, falls, or even assault. And the third one, which is not so relevant here, is cardiac procedure related, iatrogenic. So if you look at penetrating versus blunt injury, penetrating injury usually appears more severe. You know, as the picture shows, usually there's a clear history of the incident. The obvious signs and symptoms, for example, a stab wound or a gunshot wound, there is either just an entry wound or entry and exit wound. The hemodynamics depend on the site and the track of the wound. So just as a guide, if you look at the mid-clavicular line, if this wound crosses the mid-clavicular line, if you do a CT scan, you do a straight mid-clavicular line, if this line, for example, crosses the midline, then you may be dealing with a more dangerous situation. For example, a gunshot from the side, but it goes a bit more to the back, but crosses the mid-clavicular line, so that can be dangerous. Even a stab wound in the direction, medial to the mid-clavicular line is something you worry about. So the treatment has to be immediate, and the prognosis is, surprisingly, if you catch them early, if it doesn't involve too vital an organ, the prognosis is quite good. Whereas if you compare with the blunt injury, which you see more often, I think, in the emergency department, they appear less severe. The history can be a bit unclear, but one has to be very critical about the history. You need to really look in the history to look at the mechanism of injury, for example. And they may not have many obvious signs. They may have, like the last picture here, which shows some bruises, a simple thing. Maybe it looks like a seatbelt bruise. But what lies within is maybe something more worrying. So the condition can sometimes worsen over time. And maybe by then the patient may have been admitted to the ward through another specialty, for example, to the Cardiac Surgery Society site. Treatment, if delayed, you can have trouble, and the prognosis can sometimes be poor. So I mentioned earlier about the mechanism of injury. In penetrating case, history, again, I mentioned to you earlier, very clear cut. When did it happen? The duration from the time it happened to the admission into the emergency. The type and the size of the weapon is important. So that would indicate how deep the penetration is gone. And the numbers of stabs or gunshot wound, you can follow, you can track it down and see which direction it's going, whether it crosses the mid clavicular line, and the site of injury. A radiological finding is quite useful. If you look at the CT scan, you'll see that with the red line, you can see that those are some of the signs indicating the direction, the track of the penetration. A blunt injury history is extremely important. What sort of accident? What exactly happened? Did the car turn turtle? Did the other car hit directly, or was it an indirect hit? Was there a spin? Was there a sudden deceleration injury mechanism? So this will give you an idea where the injury is. I'll give an example, a simple lorry driver with a steering wheel injury or any steering wheel injury, with or without, for example, without the what do you call it, airbags inflated, you may just see bruises, but it may be something that is more severe. For example, the upper picture, it tells you that there is a sternum injury. Again, a sternal injury, you may think, oh, it's a simple, straightforward sternal injury. But if you just have a sternal injury, then you wonder, where did the energy disperse? If you find it, we have a sternal injury with ribs, you know that the dispersion is towards the rib. So that is relatively quite safe. If you don't find anything, it may be a mild injury. If the patient is osteoporotic, if the patient is a young man, very unlikely there must be some other injury. If not a rib fracture, you have to look hard for example, in my picture here I show, is a vertebral injury. So one has to be extra careful there. So of course, the clinical presentations would be hypotension, tachycardia is among the first one, pulsus paradoxus, hypotension, muffled heart sounds, and jugular venous distension. And the last three, of course, all of us know is the back striate, which is a sign of cardiac tamponade. So ECGs may show you dysrhythmias, see ST changes. Do a fast or ultrasound is very, very useful, especially you have a quick look in the pericardium, since we are specifically talking about cardiac injury. CT angiogram may be useful, again, depends on what sort of time you have. And echocardiogram, again, what sort of time you have. Sometimes this diagnosis has to be made clinically and immediate action has to be done. So an overview of the management, of course, the standard ABC. And then we may want to talk about emergency thoracotomy if the patient is extremely uncomfortable. To be honest, This is not done very often, and majority of the time when it's done, it's on the on the left side, and the injury may be a very common injury is the right atrial appendix rupture. For example, in a steering wheel injury, if you look at the structure of the heart, the right atrial appendix is actually the thinnest part. So when you have an impact on that, usually it just ruptures. So if you're on the left side, you won't be able to reach the injury on the right side. The most you can do is probably do you can release the cardiac tamponade, but that can easily be done also with a paracentesis needle. When you put in a paracentesis needle, you remove about 500 mils, just enough to prevent the shift of the heart, and quickly send up to the operating theater. That is best done that way. Okay. So, indication of surgical intervention, of course, I mentioned earlier, cardiac tamponade. If it happens, you know that it's going to happen again. You relieve the fluid, the blood. You know it's going to happen again. You need to rush to the OT. Don't worry too much about whether there's blood will be ready on time. It should work on together. As you push them, blood must be ready, O negative if you have to. Open the sternum quickly, and we usually know exactly where it is. When we open, and then we see blood in the pericardium, we open immediately, we will pack the right atrial appendage first. Suck everything out, prepare the cell saver, because that's the next thing to save the blood, to get as much blood saving as possible. Okay, so you can see from the picture, you see most of these, the last two in the end here, you can see that it's medial to the midline. So immediately it tells you, don't waste any more time, send to the surgeons, let them manage it immediately. If I see this, I'll just say, get the blood ready, go into the operating theater and just open immediately, and we will be in a better state of control. So I mentioned earlier about most of the time you get away with the median sternotomy. We can do most of the things through median sternotomy. But it is not possible at the emergency level, okay? The best thing you can do at emergency unit or even on the roadside is a lateral thoracotomy. But again, as I mentioned earlier, what is the indication? If you suspect it's a right atrial rupture, then this is actually doesn't work. But if you think it's an aortic injury, then you may want to clamp it and you'll be able to go in. But you must remember that the lung is fully inflated. It's not going to be an easy scenario. And I think most people in emergency unit will not have the experience of doing this live. So my advice is to do a lot of simulation, a lot of through dummies and all that. So when the time comes, you won't have much experience, but you do what you have to do. It's a life-saving procedure. So the best training would probably be simulation. So of course, pre, intra, and post-operative care, you have to put in the large bore lines. This we know. Surgeons may say get some cell saver depending on if it's an abdominal injury with bowel contamination. Of course, there's no place for cell saver. Usually in the chest, it's clean. We're able to do. We will quickly put in a cell saver, and in post-operatively, we'll do a thromboelastograph to check the status of the coagulation. Of course, there is a place for ECMO, but again, remember if you put in an ECMO, once you give heparin. We have the heparin bonded, heparin coated lines, which you would have less heparin, but it's still heparin. It can also bleed a lot. So one needs to know if it's a multi-organ involvement, brain bleed, splenic rupture, and all this. So ECMO is a bit out of the place. So of course, once everything is settled, ICU monitoring is important. If it's, I mentioned earlier, if it's a cardiac contusion, arrhythmia is there, the treatment may be longer than you want to. Of course, blood transfusion. Of course, repeat chest X-ray is important. Echocardiography is also important to look at this function every now and then. Prognosis, of course, there is higher survival in penetrating injury if it's rapidly intervened. Blunt injuries may have poorer outcome. Most of the time we see very simple, straightforward injury, and then we look at the lung contusion, it doesn't look as though it's progressing. But once the hemoglobin drop and they look more dyspneic, if you repeat an X-ray, you will find that more bleeding is occurring in the lung, and you realize that the patient is on aspirin or double antiplatelet, and you know you're going to be in a bit more trouble. that was when patient's prognosis gets worse. Just before I end, I want to talk specifically on aortic transection. As I mentioned earlier, this usually occurs in decelerating injury. It usually presents with widened upper mediastinum. Some of the telltale signs that you have very high rib fractures, for example, second or third rib fracture on the left side. Sometimes they come with numbness in the hand or even brachial plexus injury. And then you look at the history that it's a sudden decelerating injury, for example, a fall or an accident, car hitting the back of a stationary vehicle. You have a decelerating injury. And this may require urgent CT scan with contrast. So in our center, we used to do the operative technique, but in the last 15 years, I've pushed very hard for us to do it endovascularly. And that's what we've been doing all this while, and the result is very good. Open surgery has a 15% risk of paraplegia, whereas an endovascular will have less than 3%. So we push hard for this, and now all the cases are being done endovascularly. And the placement of the stent, the proximal anchor, is actually proximal to the subclavian artery. So during this procedure, we'll have to have a look whether the vertebral artery is a dominant artery or not. If it's dominant, this is a dangerous situation. Then we actually put a chimney, another stent up the subclavian artery, and then put a stent proximal to it. So it's important to identify the dominance of the vertebral artery. So in conclusion, cardiac trauma is of course a surgical emergency, but the good news is it doesn't happen much too often nowadays. In the advent of having airbags and people adhering to lower speed limits, and of course, as physicians at the emergency level, you need to have a very high index of suspicion, and a rapid imaging is essential. And like I told you, you don't need to go all the way to echo CT scan sometimes. Sometimes depend if it's a rupture of one of the structures in the heart. The moment it's cardiac tamponade, we just go in. We just sort of looking from the history, we sort of know where it's coming from. So early repair saves lives. So since I'm the last speaker, Mr. Chairman, I would like to take this opportunity to, this is my references for your guide. I would like to say something a bit about Malaysia since we are the last one here. This is a beautiful resort with beautiful beach and all that. But if you have the time to come to Malaysia, do come. We have beautiful beaches for diving, snorkeling. Enjoy the white beach in Malaysia. Only 3 months in the year is rain. The rest of the time it's sunny. And we have diversity in terms of our races in the country. Good religious and racial tolerance. We have all the races there. And of course, shopping and nightlife is something that we enjoy there. So with that, I would like to thank you for your kind attention.
Does anybody have any questions for our speaker? Or for any of our speakers that are here? All right, well, thank you very much. Enjoy the day.